before the train starts off and running, I'm going to do a very quick review of SBS, sphenoid-basilar symphysis stuff. Okay. See, maybe that's not catching there. I don't believe that you have to be crazy and know all the names of the dysfunctions, but I'm just going to run through them now in about 10 minutes, and then I want to do a little exercise again at the table to make sure you're fresh on it. Our ideas, our theory, that all the popular theories are, is that what we're doing with the face and the jaw is secondary to the cranial base. I don't think that's always the case, but certainly it's logical in any of the theories that you use. That whatever the problems are in the face, there's a good chance that they may be secondary to what's going on at the base. So if you don't know how to do a proper base release, and you don't know how to do a proper assessment of the sphenoid, it sort of doesn't make sense to say, oh, I'm going to go and do a zygomal release, or I'm going to do this ethmoid thing, but you haven't done the rest of the face. So when I'm doing intraoral, I'm always doing the base and then a piece of intraoral. Another visit, I'll do the base and the intraoral, and then I'll stack a couple of things together, and I'll end up running through it in just a few visits with people. So we can't escape this idea. There we go. So I'm going to spend a few minutes. This is all review for everybody in this room, I know, so I'm going to go very fast. So our theory is that the dura is shortening during flexion. AP diameter is shortening. That's what's pulling the dura up on the tube. That's what's pulling the sacral base backwards. We have this, the base of the sphenoid base of the occiput goes cephalad. Thank you, Pat. Happy. Twofer. We had a lot of different theories as to why this happens, but none of that actually matters. The theory as far as who's correct, I don't think that actually matters. We're going to spend a lot of time talking tomorrow about biodynamic theory and the anterior midline and see another viewpoint on why maybe this mechanism is happening. And actually, me personally, I think the biodynamic idea is a really nice one. It really dovetails into the energetic idea of how and why cranial works. Okay, so here's our tentorium cerebelli. It's shortening this AP diameter here, and it's just showing the forces, bringing everything up and causing everything that it's attached to move. It would be like if I'm in this room and I have hooks on me to every single wall, and then whatever motions I do, the walls had to accommodate me. That's our thinking with the dura. And if you have a question, just stop me. Stop me right in the middle and ask me. Or silently send me a message. Slip it in my pocket as I walk by, and I will address it. Because if you have a question, you're probably not the only one who has that question. A quick review of our axes. This is how we describe flexion, and this is how we describe flexion and extension. We kind of arbitrarily drew these axes that some people claim to know which molecules of the bones they go through. I don't. I just get this idea that through this base of the sphenoid, base of the occiput, if we make these two imaginary axes and we cause motion around it, this is how we found flexion and extension. So we describe flexion by the sphenoid and the occiput rotating in opposite directions around two transverse axes. That's how we describe flexion. When is flexion a dysfunction? How do we go from flexion, motion, normal, to flexion, dysfunction? This would be the audience participation part of the program. Or I will just keep talking and then I will tell you, okay? Because I see you're all warming up from coffee or whatever it is, whatever processes you need to go through. I know Paul's process from living with him for a few courses.
When it goes into flexion easily.
Pardon me?
When it has a bias towards that and won't do the other expression.
You're correct. For me, it's a dysfunction when you show up into my office and tell me you got some problem. And then I take you through all the different ranges of motion and go, well, this is where it likes to go. This is where it's stuck. This is where it prefers to go. Other than that, everybody in this room has a diagnosis. Some of you, psychological. Everybody's got a diagnosis. Mine are many. Okay? So we all have something going around, and that's the way we compensate with traumas, physical, emotional, and some people would argue spiritual things that have happened to us. We have these traumas and we adapt. That's what we do. We try to adapt. So when the patient comes in your office, they have a problem, and it prefers to go into flexion, that's when we're now going to call it a dysfunction. So there's our description of flexion. Come on now. Too early for technical difficulty. There we go. Our map for our hands, these are just the GAN pictures that I reoriented here. This is just showing that I took you through a little hand thing like this, right? So this was flexion. And we showed whatever fingers you're using, greater wing fingers or greater wing thumbs, and base of the occiput, that during flexion, this is going down to the feet. When we say going down to the feet, we're talking about cranial theories, something on the order of less than 500 microns. Can everybody hear me? Sarah, can you hear me? Am I loud enough? Am I loud enough, Paige? Okay. So, I don't know. I'm not a researcher, so I can't tell you what their current thing is. I don't know if anybody's ever measured this or not. I'm always hearing that they've been measuring all these things. And then when you read it, the experiment had like 3 people in it, and you know, it was a party at somebody's house, so I don't know if it's really, any of this has been verified. But what we theorize is it's less than a half a millimeter of motion. So it's less than half a millimeter of motion. I'm going like this so you get the idea of where the bones are moving, but it's going to be not perceptible to the visual eye. So here's flexion. This is the base of the sphenoid, base of the occiput, coming cephalad. The part that we can touch, because we touch the greater wing of the sphenoid and we touch the occipital squama, is going down to the feet. Everybody cool on that? If you're not, speak now. Today's a wedding. Speak now or forever hold your peace. Or don't hold your peace. So, we're Americans, we don't hold our peace. We just say whatever we want. We say what we want, when we want, how we want. Oh good, that started. I was worried that it might not start until later on. The extension, just using our same model. You know what, Pat, it's me. Clearly, because I'm not staying with Paul, and he got here early this time. And there's a whole humming procedure that goes on in that house. You don't know. I've outed you, Paul. I've outed you. Okay, so extension is just the opposite. Once. And enjoying it all the way. Okay, so this is flexion, coming backward along those same 2 transverse axes, occiput and sphenoid turning opposite along those 2 axes. This is what we call extension. We call it an extension dysfunction when it prefers to go that way, when it's stuck that way. For our hands, this is fingers coming back to your chest. The part that we don't palpate, going down to the feet. The part that we do palpate, coming back to your chest. That's what that diagram is showing. Torsion dysfunctions. Torsion is just a mechanical term for, torsion is this. It's the way you get water out of the dish rag. If the dish rag has an axis between your hands and you twist in opposite directions. So to describe a torsion dysfunction, what we did was draw an AP diameter from nasion to opistheon, if you read the cranial books. These things, just keep in mind, people are trying to give you a mechanical idea for what we all experience. Whether you're calling it whatever different theory, we're all experiencing this. So whether this axis would actually be here or a little off, I don't think it matters. I think we still palpate that idea of a torsion at the base of the sphenoid and the base of the occiput. That's what it means. It means where those 2 bones meet, it's such a shame to pull this all apart because it never is going to go back together. Is this Michael? Where's Michael? Is this the one with the magnets?
Yes.
Nice. Yeah. I got one, of course, just before they started doing the ones with magnets.
So, the rubber pads?
Yeah, that break off. And, my son has my old office now. It used to be us together. The first thing I do, because I gave everything to him when I left, so the first thing I do is I pull the skull apart and leave all the pieces on the desk. I do. Just to piss him off. That's the reason why I do it.
Flash quiz.
Pardon me?
Flash quiz.
He gets irritated with me because he's since I'm living in Thailand, he'll email me a patient question, which is fine and all that. And I always force him to read some anatomy or physiology before I'll answer the question. So you just asking me, or did you bother to look at anything? Because in his case, I know he didn't. He just wants the cliff notes on all of life. So I'm not doing that for you. You go read something. All right, so torsion. Torsion describes torque at the junction between these two bones. That's it. Is it going through flexion and extension while it's in torsion? That would be the question that I've asked myself many, many late nights. It's in torsion. Does it still go through flexion and extension? You got a 50% chance to get this one. And I'll let you use a lifeline. You can ask Molly now.
I can say yes.
Yeah, it's going through it. What do you feel in the head? You just feel the head feels weird. I'm not one of these people who puts my hand on the head, looks at somebody walking the door, and makes a diagnosis. Just quickly taken through a range of motion. So you're feeling somebody's head going through flexion and extension. You go, well, that just doesn't. It feels off to me. And then when you take them through the torsion patterns, this will feel easier, the right torsion, because they're in that pattern. That's what that means. Painful. Okay, so what I've shown here on this is the right torsion, meaning if a patient's standing just this way, the right greater wing is high. And that's the nomenclature that Sutherland used, and so we just stick with that. Here's a back view, same way that I'm standing, just this way. The right greater wing is high, which means the left greater wing is down. The fingers. So this is going to be our flexion, this is extension, this is right torsion, and that's left torsion. It's the right greater wing coming high. High, if this person is a patient laying on this table with feet going out this window, head going back this way, high is that way, that's high. High is a bad word. Cephalad is the way we should talk. Okay, we use the same axis to talk about rotation. Again, mechanical principle. If I take the dishcloth and I rotate it, no water comes out of it. So we talked about the rotation side bending dysfunction, and I broke it down to you for rotation, which is greater wing and occiput both rotating around that same axis. Okay, this is occiput and greater wing both turning. And side bending dysfunction. And Dr. Sutherland puts it all together, rotation side bending dysfunction, that you find this together. That's the way I was taught. Where you find one, you must find the other. My experience has been, you find what you find. If you find somebody has a rotation dysfunction, is that possible? I think it is. In the osteopathic world, there's a lot of people. There's some people that are progressive and some people that are part of the Flat Earth Society, so they will just keep parroting whatever it is that Dr. Sutherland said. But when you have that patient on the table, if you find that they have a rotation dysfunction and they're not side bent, the question you want to ask yourself, Mona, is should I treat that as a side bending dysfunction, rotation side bending dysfunction, or just treat what I find? That's it. That's the best way to proceed. You can always do better treating what you find, not what I told you or what someone else told you. So we describe right side bending this way. The side bending is that between these two bones, that this is side bending. So we're saying side bending, rotation, dysfunction. What should you palpate on your hands? This. So I'll just stand this way. If this is flexion, extension, right torsion, left torsion, right side bending. I want you to at least have it conceptually in your head while I'm talking now that this is side bending and understand why that is. That this is rotation. Understand why that is. I'm going to talk to the window now, so I'm not sure if you'll hear me. So, this is side bending. If you're not clear on that, I want to make you clear when we get to the tables in just a minute. If my fingers are here and here, which I'm not going to be able to do this, that's why the fingers are opening up. Side bending. Rotation. That's what's being shown by here. Okay. Strains. We describe strains by using two vertical axes rotating in the same direction. they rotate in opposite directions about these two parallel vertical axes, what would you call it? You would call it, if they rotate in the same, in opposite directions about these two axes, what would you call it? The chair will now recognize Paul. I'm giving you an example. I'm showing you right lateral strain, okay, which is these two rotating in the same direction about two parallel vertical axes. But if they're rotating in opposite directions around two parallel vertical axes, what would you call it?
Shear.
No. So you're looking at the picture there. The picture there is showing these turning in the same direction. So we're calling that a shear. They are rotating in the same direction. My question to you, young Paul, is if they rotate in opposite directions, what would you call it?
Torsion?
No. I don't know why this question perplexes people every time I get to this spot and ask people, because you're just inventing something that's not there. Look at the picture. What I'm saying to you is, if these turn, this picture is showing you turn. I have to get my hands moving right. Turning in the same direction. Let me have two boxes. Where's the gloves?
Right there.
I know, but I need another one. You have two boxes that are the same size?
I think you did it with phones.
You see? I did. I'm going to do boxes now.
It's big.
Boxes. This is turning in the same direction. If I turn them in opposite directions, what are we going to call it? No. This is shear.
Straight rotation, no?
No. A good guess though, but no.
Side bend.
Yes, side bending. I don't know why this is so hard. It doesn't mean that you have a problem in your brain. Just everybody, no matter where I go, and I get to this part, and I like to go back and ask the same question, and everybody is waiting for some new information. No, this is shear. This is opposite direction. This is the side bending. Okay. Yes.
So the difference between side bending and torsion is that there's an element of flexion.
I didn't say torsion.
I know, but I'm just
Okay.
getting it clear that there's an element of flexion in torsion, but not in side bending.
The difference between torsion and side bending, is that what you're saying?
Yeah.
They're not even the same animal. So when you're saying the difference between shear and side bending, is that what you
No,
need to say?
I'm asking about.
Okay,
I'm going back. I'm going
okay.
back to where we came from.
They're all going through flexion and extension, but somehow dysfunctionally.
Can you show torsion with the boxes, please?
I can. This is torsion. This is side bending. This is shear.
Okay.
Is shear more rare?
I'm not a statistician, so I couldn't really tell you. People that are coming in my office have a problem. So all these dysfunctions I'm seeing, I'll say what I'm seeing the least would be a vertical shear, a vertical strain. But there's a lot of things that I call compression that other people might not. Because I know I've given you my verbiage on the importance of language. Language is me calling Martine and telling him what I have with the patient, or him telling me, and we understand the language for each other. For being specific about science and insurance companies, nobody cares. So statistically, I'm not seeing vertical shears that much, but I'm seeing a lot of compressions, which compression should be nothing's moving at all. Well, that's a dead person. That's a person who has now transcended our problems here. But I'm calling things mild, moderate, severe, poor motion in all directions. So lateral strains, see them. Side bending rotation, all these I'm seeing. I can't say I'm seeing that much flexion and extension. I just don't think it's that much of a problem. That's just Steve Sanic conceptualizing. So I'm not seeing a lot what I would call flexion or extension, or vertical. Vertical is problematic to get it, actually. To have the mechanics to make that happen to you, something's really got to be wrong. And you're symptomatic. If you have a severe, what I would call a severe shear of any kind, you probably have some problem. But I'm not sampling normal people. Does that answer your question, or have I obfuscated long enough to get out of answering it?
No, when I work on people, I never feel like I find shear or like a.
Don't know how to answer that question. They have them. They have them. Okay, so this was, fingers are a little hard to guess for this. So again, I'm going to stand the way you're facing. Flexion, extension, right torsion, left torsion, right side bending, rotation, left side bending, rotation. The pinkies tell you which way it's going, right lateral shear, left lateral shear. And last one, well, we saw these axes for vertical strains. When they're going in opposite directions, what do we call it?
Sheer.
No. When they're going in opposite directions around these axes, what do we call it?
Side bending.
Sheer. Sheer.
No. No. No.
Lateral street.
No. Where did you just see this picture? We started out with this picture. Where did you just see it? Don't feel bad, because I did the diagnosing wrong, and I was on the chairman of the credentials for the Cranial Academy for a lot of years.
Should go in the same direction or opposite?
If I take the sphenoid and the occiput and I rotate them about these axes in the opposite directions, what would you call it?
Flexion or extension?
That's it, thank you. Flexion extension.
Begin.
I think they're trying to trick us.
I am. Because
Yeah, well, he did.
the verbiage is tricky and everybody steps into the same hole. It's me, Ned Ryerson. That's a reference to the Groundhog Day movie, one of the greatest movies a person can ever see in their lifetime. You agree with me on that, Martine?
Yes, sir.
Needle Nose Ned, Ned the Head. Case Western High. Needle Nose Ned. Got the shingles real bad, almost didn't graduate. Ned. Did a whistling belly button routine. Ned. Dated your sister Mary Pat till you told me not to anymore. Ned Ryerson. See, that's my other career I'm
It's
working
an
on.
insurance salesman.
What a
Doesn't
shock.
he?
You and I were going to have some private time on this one. Yes, so it's the same thing. Every day Ned Ryerson steps into that same water hole. That's my Ned Ryerson reference for those of you that are not in the same mental institution I'm headed to. Okay, so this is how we described our superior strains. If we said, I really like the boxes, they're just easy to work with. If I said that this is our lateral shear, then this is our vertical shear. And I'm not seeing it much. Maybe it's just me. So there's our superior strain. Our nomenclature was to name what? To name where the base of the sphenoid goes.
Can you just show superior strain again, please?
Sure can. With fingers?
Sure.
Is that what you want?
Yeah.
Coming at you. 3D. Okay, superior shear is going to be where the pinkies are going. Okay? The pinkies are going to tell you where the occipital squame is going.
Okay.
So in this case, this is the part that you don't feel. The part that you feel is here and here. So the pinkies are going where? Ceph Ladd or Caudad? Look at right here and tell me, are they going up or down?
Caudad.
You're-
No, cephalad.
Right. Okay, so if this part of the occiput is going up, then it means that this part of the sphenoid is going up. And the greater wing, which you palpate with this finger, is going down to the feet.
Okay.
So flexion, extension, right torsion, left torsion, right side bending, dysfunction, left side bending, rotation, dysfunction, right lateral shear, left lateral shear, superior shear, and that's going to be inferior.
Steve,
You
when
know,
you do the fingers, could you put them over your head? Because all I see is one hand in your head.
I can. So, is this good?
Yeah.
Flexion, extension, right torsion, left torsion, right side bending, open these fingers, right rotation, left side bending, left rotation, right lateral shear, left lateral shear, superior shear, inferior shear. Okay? And I can do it for your phone as well. Maybe in a little.
On TV. On the video.
All right. Again, if you botch up the hands and you botch up the naming, I don't particularly think it matters for treatment. What matters is you take them to a range of motion. If you take them to a range of motion, you'll fix the problem. And then if you go on, they still have the problem with the zygomatic problem with the other facial bones, dental things that we're doing. You should have done this first. That's my take-home point. You should have done this first. Okay, so our inferior shear is, again, these are moving. This tricks people, and I don't know another way to do it and have it on the slide. They think that they're rotating in opposite directions because of these arrows. But they're not. They're rotating in the same direction. This is going clockwise. This is also going clockwise. The reason why it's tricky is because I have the two arrows together, because otherwise the space looks funny. They're rotating in the same direction. When they rotate in opposite directions, it's flexion and extension. And if you read, you should, I think it's nice to have anyway. Osteopathy in the cranial field, it used to be a secret tomb that the Cranial Academy wouldn't share with anybody, but I'm sure you can get it off of Amazon now and you can get whatever. It's something you should just put in your library, only because Sutherland didn't write it, but he approved it. Magoon put all this anatomy in there. He was one of the original students, and they took it to Sutherland and said, "You approval of what this says?" And he said yes. And everyone has extracted things from there. So it's a little dictionary you should have, osteopathy in the cranial field. So this is however you're palpating. This is how I was shown to do it. This is how I end up doing it, because big hands. So this is flexion. This is extension. This is right torsion. This person who's in right torsion continues to go through flexion and extension. Your palpation of the head is just that something's off. But when you take them physically through flexion, extension, right torsion, this will be the thing that feels easy. And if this feels easy, what should feel most difficult? The exact opposite of that same dysfunction. It's your little checks and balance for it. Is that right that it's in right torsion? It feels easy. I'm not sure. Well, if that's right, it should absolutely be most difficult trying to do left torsion, because that's the exact opposite to what it wants to do. Left torsion. Right side bending. Okay? He's describing side bending the same way you would describe a vertebral segment. It has side bent, and then it has rotated. Left side bending, rotation. Right shear. It's where the sphenoid, the base of the sphenoid has gone relative to the occiput. That's right shear, left shear, superior shear, inferior shear. Compression, what do we call compression? I call it when I feel poor motion in all directions and I can't decide. Then I say it's compressed.
When you say poor motion in all directions, like you're having trouble moving it, or it feels like
I can't decide. Everything's
restricted, and that's it.
For me, someone who has compression, my lay speech for that would be bowling ball head, or a medical student who now became an eye cancer surgeon. Spent her entire life in school. I called her Concretia when she was a student. I still call her that when I see her on Facebook now. After 100,000 years of school, that's like as much school as you could be in forever. She had to do oncology, she had to do internal medicine, she had to do ophthalmology, and just now starting to work for actual money. And I nicknamed her in medical school Concretia, because it was just like a bowling ball head. Everything's tight, and she had a bowling ball head. Do you think she was symptomatic? Yeah, all bowling ball heads are symptomatic. What's the most common symptom? Headache. Yeah. Number one reason why people go to see their Bacteria therapist or tarot card readings, back pain. Number two reason, neck, head. You can include the two together, neck and head pain. Okay? So, with the boxes. Okay? Flexion, extension, right torsion, left torsion, right side bend. Sorry. How do I do this? This way. I'm sorry. This is I'm going to do the boxes this way. So the person is facing down toward Mona. Okay. Flexion, extension, right torsion, left torsion, right side bending, rotation, left side bending, rotation, right lateral shear, left lateral shear, superior shear, inferior shear. Compression, you take them through all these ranges of motion, you can't decide, but it feels very difficult. How do you define very difficult? You define that based on your experience. If you're someone who's a new therapist, you need to get a little bit of time and rank, and you'll get that idea. If you're plenty of people in this room have plenty of years of experience, it's what feels really bad to you and you can't decide. Call it compression. What if you've called it the wrong name? They will die within 24 hours. Okay? No, they'll get better if you treat them and take them through ranges of motion. This doesn't require you. This does not require you to sit there and feel the rhythm. You're going to work really fast if you do mobility. You can stop, feel the rhythm, and try and increase the rhythm. Always you can do that. But the only way that I was seeing 3 people an hour of complicated problems, and treatment time about 16 minutes going from head to toe, was going through mobility and then briefly taking moments to listen to the motility.
Steve, could you tell us the order in which?
It's just an order that I find easy to do.
Okay.
I'm going to come over there.
So the top of the temple.
I shouldn't see your hands move, but I'm going to move my hands. It's just, I always follow the same order. That way I'm not having to make up my pattern every time I'm doing it. And I go flexion, extension, right torsion. Ah, yeah, that's right. Yeah, don't let any other kind of twisting like this happen. It's just purely this way. Okay? So this is right torsion, left torsion. Right side bending is you opening your fingers, and right rotation down to the feet. And back, and then left side bending, left rotation, and come back. Right lateral shear, left lateral shear, superior shear, inferior shear. I'm always just going through, so I don't have to think about it. I put my hands on and I just start going through those motions. Okay, good, does move. So we have, let's just take a segment. We say that, you know, L whatever is side bending, this segment here, side bending, rotating to the left. Side bend, rotated to the left. Where's the problem, on the left or the right?
Right, we don't know.
On the right?
It could be.
Could be either, could be either, could be either. I have no idea where the problem is. Okay, you separate your mind from it's a right torsion, therefore the problem is on the right side of the body. What you're saying is this building block is in some sort of placement. In osteopathic terminology, we're going to say it's side bent, rotated a certain way. Chiropractors will say the spine process is pointing another way. And we're all having different verbs to describe the same malalignment of something. How it's interacting with the rest of the body and where you find that problem is not necessarily the right side, the left side. I don't know a rule for that. Okay.
So given that same thing, like one person would have a problem on the right side because of the compression, the other person would be bitten, if you will, on the left side because of it being overstretched.
I like the way you think. They would be bitten.
Like it bites back, you know, like too much, you know.
I just don't know what it will be.
Well, yeah, so
You know-
Sandy, what you're saying is that if we try to diagnose based on
One
bony
piece of
placement
information.
in space, we are those that do that are really shooting for symmetry. But what we want is we're shooting for movement and adaptability in all directions. And
I
so
agree
it
with
doesn't
that.
matter what the placement of the structure is in space. It matters its relationship to all the adjacent.
I agree with that 1,000% what you just said. You said it very, very well.
Fuck symmetry.
I wouldn't have said that because he's making a tape of me. So, but I agree with both things that you said, including the last one. But think of it like this: something's out of place, whether it's bony, whether it's fascial, whether it's an organ, whatever style of manipulation you want to call it, doesn't matter. That thing out of place causes what to happen? It causes compensation somewhere else in the body. So I don't know what the complaint will be, whether it's above the problem, below the problem, or at the problem. But a dysfunction that's rotated to the left, turned to the left, doing this to the left doesn't mean left problem. It means this thing is out of place. So whether you correct it by releasing fascia and it finds its own place, or moving the bones back to a place so it doesn't matter. But I don't know how to make a formula for that. Mike does, but he's not
So you're
telling, he's not
saying no.
sharing how to do
Selling
that.
the book though.
Sell the book. And the movie rights. All right, now I want to move on to a different idea.
Got the right TA.
I told you the important sense of humor is just don't feed him. Keep your hands away from his mouth. Yeah. Don't put any beer in him. You'll get nothing useful after that. For me, for that matter. Okay, my burning truck scenario. This is why people come to us. So this is my analogy of why people come to us.
Not because of the burning bush, it's the burning bus.
It's the burning bus, and we can go old school on that if we need to. But something's burning, either psychological or physical or whatever. Patients either comes here with a stack of notes from the last 10 people that tried to figure out their problems, or all these things to try and point us in a direction. But they really, this is all clueless for me. I don't know what to do with that. I always weigh the stack when they give it to me, and then I look at the, I don't even look at it anymore, but I used to look at the x-rays for marker sign to see the radiologist. The guy went to study 4 years how to read it, instead of what I did in medical school, and I go, yeah, they've marked this in red. This is important. I'm being a little bit tongue-in-cheek with you. I know how to read them, but I'm not going to, it's unlikely that I'm going to find something different that the radiologist found on their MRIs and whatnot. And everybody's found this information and pointed to it and said, hey, Hisham, nice to see you. So, and then they've said, here's your problem. Okay, so you go in an orthopedic way and they go, well, you got a herniated disc, this is why you have your back problem. And I'm not arguing that it is or it isn't. It's a huge component, obviously. So they come to you with all this information, but as far as treating them, it's been easier for me, pressure-wise, and more successful for me in throwing that all in the garbage. I give it its due respect from the patient. Okay, yep, I look at the findings very quickly, what other people found. So I've done due diligence, and then I wash it all out of my mind. And it's an important skill, whether you're doing cranial or visceral or whatever style of thing you're doing, to get some other picture. The concept of key lesion, at least we have that in osteopathy, and so do others. It's an old idea that there's some lesion that is key, that is more priority. And that if we can do something for that, that will help either this problem they're complaining about or their overall compensation, it will contribute to their overall wellness. When I interviewed people, I asked them about that. It was one of the questions I asked just for personal interest. And some of the great people I interviewed said no, they don't believe in that concept at all. And others said they did. So I think you can practice, for me, osteopathically, you can practice any way at all. It includes all diversity. It's not one set of rules. But this concept, this has been useful for me. I want to share the idea with you. Key lesion, I was kind of presented this like you're finding this needle in a haystack. You know, you're going to find this key. If I can just find this and unlock this, all wellness and good things are going to come. Okay, and I agree with that, but this is my experience. This is the needle in the haystack. If it's key, it's really a problem. How can it be key and impossible to find? That doesn't make sense to me. It just doesn't. It's a key lesion, but I gotta be a grand wizard or something. No, I really have to dumb myself down, easy for me to do, okay, and not listen. Not listen to what the patient's telling me, not listen to what all their other therapists said, not because people aren't wrong or they're not right or they're not smart. It's just more voices. I need to put my hands on their body and say, where do I find the big needle in the big haystack? Okay, and I'm going to choose to do it with cranial. We'll do it visceral, and another visceral way that I know a lot of you are probably doing. I find cranial just to be the easiest for me. And since we're doing a cranial course, so we're going to do this idea, I've learned from some called it arcing, some called it fascial glide, some called whatever they want to call it, but I'm going to grab the ankles and I'm going to swing around and see what I can feel on their fascia really quickly. That's going to be the key with a global diagnosis for me. To find some global problem, you are not going to go into a psychic phase. Be no chanting, you won't be spending an amount of time, it'll be really quick because it's going to be a reflex. So when you touch their body quickly, the area that highlights to you, that's what it is, and that's what I'm going to work with. It's not something that I'm having feedback with the patient, oh, I found this key lesion on you today, or with their other doctors who already believe I'm insane, that may not actually be incorrect. It's just information for me. So you have headaches and I found that you have some problem in your abdomen, I know that I'm going to also treat that. And my efficacy, my ability to help people was dramatically increased from that compared to just targeting whatever they complain about their problems, this idea of key lesion. What I tried to show in my original drawing that Da Vinci stole from me is that if the key lesion is right here, then if that's key, if that's that big needle in a big haystack, then when I'm pulling the fascia or I am, the arcing comes from, this is making an arc, which is a section of a circle. But whether I'm pulling on the small section of a circle or I'm just pulling at ends of their fascia, the tightness, the center of that tightness is what I'm showing should be here. We should be able to triangulate it by pulling on their feet. That's the idea. If this was the key lesion up here and this is where that perfect circle would be and I'm holding the feet, there should be some different feeling that triangulates and points me toward that. I'm going to explain it another way. I'm going to explain it a few ways and try and, I don't know if I have the right words for it. A person doesn't have a lesion. They are a series of different discombobulations that are happening to them. And what I've tried to draw is more rings, this is a bigger problem. So here's the key problem, okay? So 1, 2, 3. So they have these things going on. What I'm going to do is I'm going to pull on the fascia. I should be able to figure that out. I should be able to find it. And I'm going to demonstrate it here, and then we're going to do it with each other. Oops, wait a minute. What happened? There we go. And I'm going to put my hands across them bilaterally, very briefly. A few seconds. I'm going to start at the feet. A few seconds. Then I'm going to go to the tibias. Then I'm going to go to the femurs. These are not magic places. They're just quick listening stations for me. Then I'm going to go across the hips. I'm going to come down to the lower rib cage, shoulders, and head. And if these places, if this is really key, then I should feel a pattern should start to emerge pretty quickly. And that is when you were children, you did this game with brothers, sisters, or strange people, the hot and cold game. You know, where's the cup? You know, you're getting hotter, 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 you're getting colder. Oh, you're ice cold now, you're ice cold. Oh, no, you're on fire, you're on fire. Okay? I could teach a child to do this because that game is still fresh. If this is the key lesion, then I should be able to feel it. Maybe I don't feel it from this far away, but as I get closer to it, I should feel I'm getting hotter, 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 and this side should feel more dysfunctional than this side. And if I'm choosing to talk about cranial, the simplest thing for us to do is to feel amplitude. What is amplitude? Mitch? Amplitude is the bigness of the feel, the boom. You know, you feel the cranial rhythm. I feel a big rhythm. That's amplitude. We got two things we can feel, amplitude and rate. So when I put my hands on, all I'm feeling for is, wow, do I feel a big breath of something? Does this side feel better than that side? They feel kind of the same. My choices are, they feel the same, this one feels better, that one feels better. Those are my choices. Narrow, very narrow field. So I would expect to feel, if it was just this one set of circles, I would expect to feel decreased amplitude the closer I get to it. It's the big needle and the big haystack. If I'm down here at the feet, I would say, well, these kind of feel the same to me. Now as I come up here, I'd go, well, this one feels less than this one. I'm not drawing this picture, I'm just experiencing it quickly. And then I start to come here, I go, well, this still feels bad, this still feels better. So I come up here, I can say, this hand feels pretty good, and this one feels bad. You start to triangulate with your hands. Third way of thinking about it. If this is the key lesion, then it's screaming from everywhere. If you're doing reflexology, I don't do it, I don't know it. Okay, but you should be able to read this somewhere in the feet. If you're doing iridology, you should see something in the eyes. Everywhere the body should be recognizing that this is a big problem, because we're saying it's a big problem. It's not a cranial problem. I don't care what Hisham has told you privately. It's not a cranial problem. I'm going to tease him because he's my friend and he's very shy. So don't get him upset. I don't know what he'll do if he's upset. Okay, so it's not a cranial problem. It's not a visceral problem. It's not a meridian problem. It's an everything problem. If this is key, it's key. So again, I don't think it's hiding from us. There we go. My last. This is from.
Wow.
Who asked me if I get a lot of sleep? Someone asked me this morning. Yeah, I don't sleep much, so constantly playing with PowerPoints. Okay, no, that's for teeth. Okay, so here's how we're going to do this. Let me just have someone lay down here. Head here, feet here. Anyone? Is this upsetting, or I can well,
Need more cowbell.
You can relax.
More cowbell.
Okay, can you just spin around, put your head down that end? And just kick your shoes off.
John, if anyone says I don't understand, I can say I've walked a mile in your shoes.
Okay, relax. You don't need to do anything. I'm going to pick your feet up. You're not going to help me. I'm going to do this with her, and I'm going to tell you what I find. With babies, I'm not doing this. With every adult, I do it. That's it. I never discuss with a patient, what are you doing? No, I'm just feeling professional attention. One, I don't feel like getting into the whole psychotic discussion of something that they can't relate with, and this is somehow going to be the way that I'm going to fix their problem. I have no interest in doing that. Some people, if they're body workers or they're cool, whatever, yeah, we could have a discussion. My job is to fix something. When I do this, if I'm going to put that pin in her, it's somewhere in her lower hip. I'm glad she's agreeing with me. There'll be a little something extra for you after the class. But it really doesn't matter. It doesn't matter if she agrees and goes, oh yeah, that's what something happened to me. It's just what I'm finding now. So if she comes in and says, well, you know what the problem is, blah, 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 blah. I know that this area is going to get a little extra investigation. Doesn't matter if she says, it's my earlobe that hurts. So this is the number one thing that comes out to me. Number two, somewhere around here. And then there's nothing in here. There's nothing here at all. And then, maybe one of her ankles felt something distant, but I'm not going to count it. So for me, I want to look for 1, 2 things, that's it. I find something here, I find something here. Anything bothering you?
Sure.
Is it a long list?
No.
What's bothering you?
My right shoulder, posterior rib cage, vague thorax.
Okay. Does anything bother down here? Because you're nodding your
This is
head.
something old, chronic, I don't know what it is. So this is old, I don't know what it is. I don't feel it, but I know it's there. You
Okay.
know what I mean?
Yeah, I think it'll be okay. We'll never get the pine box through the door. So, it is what it is. Now, let's talk about something for a moment before we do this in groups. We're going to break into maybe 3 groups and do this. Can anybody find something different than what I find? Yeah. There's that inter-operator interaction. My experience with some really great people in different names that many of you are familiar with is just that some people are going to say, well, we all going to find the same thing and we're going to have agreement, and other people might say, well, the body showed this to you and the body showed that to me. I subscribe really to that last one. Not because I'm into the peace and love and we're all right and we're all good, but we're all body workers, so we're sensitive to different things. So I think you can show different things. If this foot is on backwards and pointing back down to the ground, well, we really all should probably agree that that foot's backwards and pointing down to the ground. Or if we're doing muscle energy and we want to talk about segment is side bent left and rotated right, no, we should all find that. But when you're in an energetic, organic, and that's what we're going to dovetail onto when we start talking about anterior midline world, and when I don't believe we're better people. Let's just say if you're tuning into that and you're looking for that, I think you're going to find different things. And maybe there's one way I'm going to help her, and there's another way that Mona's going to help her. And I'm not going to say which way is better. I don't know who needs what when. So we can find different things. We don't have to have agreement. So let's break up into two big groups.
Steve,
Yes.
when you're assessing it, are you looking for things like heaviness or heat or anything, or is it just what you're drawn towards?
Drawn is the best word, and it's really an amorphous word because it doesn't clarify for anybody. But if you're tuning into the cranial rhythm, I've watched people do arcing like this. I've watched this in classes, and I'm being a little bit hyperbolic, but it doesn't matter how much I do this, her buttocks is not coming off the table. So if that's what I'm requiring to see where that fascial drag is, it's not that. I can assess it, I just got to take the weight off of her feet. If we want to call this a fascial model, and I'm saying the pin's right there in the hip, that feels like the biggest. She says oldest, I don't know, and I don't try and correlate with her. It's just what I feel. If I go over her with a microscope and I look here, am I going to find something? Sure I am. Everybody, if they look long enough, they're going to find something that will resonate with her or resonate with you. Whether it's worthwhile for your time, that I don't know. So here, this is, and heat-wise, a lot of heat coming off that. Well, when I say heat, there's a lot of change coming off it. If I actually go slow, I can't tell if it's hotter or colder, but this is the big needle in the big haystack. This is a big needle in a big haystack.
Do you get a sense of the depth, whether it's more AP or
Whether it's more what?
within front back, within that quadrant where you're
and my initial assessment, no. I go, this is the area. Maybe I do, maybe I don't, but mostly I go, there's something here. Then when I come to my listening stations, I go, this is the hotter, colder, hotter, getting slow, dead, slow, and it goes away. In my investigation, when I come to this area, Yeah, I'll get a sense of, I felt this, I felt that. But I'm gonna get that on local inspection. All I wanna get from the initial thing is something that she's just not capable of telling me. Just global, just throw a dart at the map. Where do I think I wanna start at? And that's been very, very helpful to me. Yes, Mitch?
If a colleague follows you and does that test and says to you, gee, Steve, you know, I'm not feeling that at all. I'm getting a sensation that it's coming from someplace else. What do you do in terms of...
My advice to you,
Yes.
you treat what you found.
Okay.
You can't treat what Steve told you. You can if I say L4 is side bent left and rotated right, correct that. The abdomen is rotated forward, correct that. Yeah. You know, if we're doing muscle energy, everyone here should be able to address that. But if you found whatever you're going to call that psychic tension, muscle tension, big needle and a big haystack, and it drove you to right here, I'm going to tell you, you're going to be better off for that patient, you addressing what Mitch found, than what Steve directs you to find.
So that's true what you find.
That's what I'm doing.
Okay. What about communication with colleagues then in terms of describing?
Give me a situation. She comes in and she complains of what, and I find what. Give me a situation.
Well, a moment ago, a few moments ago, you had said in communicating with,
You can sit up, thank you.
with another osteopath, you have a commonality of language that you can describe.
We would like to believe that, yes.
Okay.
Okay.
But
If I'm talking to you
Yeah.
about this exercise, I say, well, you know, Mitch, when I did that global diagnosis, I was really drawn to the left side of her pelvis. That's exactly what I would say to you.
Okay.
I wouldn't write it in a note. I'm not making things like that. And you might say, okay, or if it was your patient, you go, what'd you find? I said, well, you know, and then I'll look and whatever I specifically find, I can say, I found this with the organs, I found this with the fascia, I found this with the bones. And I'm probably not going to go over like the global assessment. But osteopaths might be a bunch like other practitioners. People will say to me, one of my favorite things is someone going, well, you know, my family doctor's a DO, how come they don't do this? That opens up a whole long discussion. Okay, the only thing they do is a pen and paper and prescription and pills. Or I went to another cranial person and they found this. You know, I don't know what to do with that. My approach to it has always been this. I go, here's what I'm finding. I don't attack what other people found. I don't know what they found. And I go, if that fixed your problem, why are you here now? It doesn't really matter. And I'm not trying to be king of the heap. I found this, the other person's dead wrong. I never done that, unless it's something dangerous. People are avoiding getting treatment, and I think they got something malignant or they got something dangerous. Then I will say that person's wrong. You need to go get this addressed. So, am I still not answering the question?
Well, it seems we have this discussion in every class.
We can have it because you're not the only one who's
Yeah,
you're not the only one who's thinking it. Did I answer it? Okay. Please ask it because you're not the only one who's thinking it, Mitch.
So
If
when you're
you're
going through the listening stages, you're actually attuned to the cranial rhythm.
Yes,
You're-
quickly.
That's what you're doing.
Everyone in this room, I'm going to give you something everyone can identify with. You turn the radio on, don't like that song, not that one, not that one. Your brains can process instantaneously. Bop, bop, and you're like, that song sucks. Turn it off and you go to the next thing. All I'm feeling for, life, no life. Life, no life. Life, no life.
Steve, why bother with that movement if you're feeling for the cranial rhythm?
I was shown it,
Okay.
and I'm a creature of habit.
Echolocation.
I like that.
Echolocation. What
I like
maps do. So when you put a wave or a movement through, the feedback is that same thing Bass do, that echolocation. That's what Traeger does.
I like that. I like the wording. I like the whole
Put a
thing.
little bounce in it and what comes back at you. Wake up a little something.
Call it whatever it is. If this is, you know, my other, and I think we did this. We could probably use my code because it's probably the biggest code in here. So we'll do a little example here with my code, since we don't have a bed sheet. My dad always said he got his clothes made from Omar the tent maker. So let me have Sarah come up. I'm going to Omar the tent maker also. Here we go. No, stand here, please. think this will sort of work. Now, hold that. Hold that, both hands. Now, Paul, put your, okay, now, here's what I want you to do. Just a little bit like that, okay? Okay, now, we're gonna call this 1. Now, just move your hands a little bit. Okay? Okay, now stop. Now do it. 2. Stop. 3. Okay? Now, close your eyes. Close your eyes. Okay, now swing. Top, middle, or bottom?
Top.
Keep your eyes closed. Okay, stop.
Put it down.
Okay, do it again. How about now? Yeah, I'm not fooling you. Okay, and this is just a simple demonstration. Body's more complicated than that, but whether it's fascial or cranial, I don't know. That first assessment, I go, the nail in the coffin is right here. I feel it here, here, here. I like what Ray said, that if you Traeger, you call it echolocation. Cool name, whatever it is, I don't know. Okay, but I'm feeling something, I go, I'm starting here. If that feels tightest to me, then I should also feel with depressed cranial rhythm. I should also feel her kidney motility should be poor around that area. It should be affected by it. If you're somebody who does TCUM, which is a lot of you in this room, you can probably make some correlation to something there. Okay? It's key. Big needle in a big haystack. So Molly asked me, said, well, for one of these cranial dysfunctions, shouldn't you find that there's an AO problem? And I said, no, not necessarily. And she said, well, I think that you should. And I suddenly realized we're on 2 different pages with this. Because this is not a radiographic finding. This is a radiographic finding, meaning if I take an x-ray and you see this is a basilar skull fracture of a dead person. Okay, it's not a live person. So if this squashed middle cranial fossa, if this is it, this is a post-mortem photo, which I have plenty that I can show you for another course that I do. You're not seeing this at all. You're not seeing this, side bending, rotation, none of it. So, no, you don't have to have the AO dysfunction with what we're palpating here. The other comment I want to make is, take this cranial model and think of it as a bony fascial complex. Don't think of it as just a cranial bone thing. So I'm going like this because I don't know another way to help you understand the mechanical idea of mechanics that are non-photographiable. Flexion, extension, but I shouldn't see your fingers move, but there's a sensation of movement. Last thing, the sensation of movement, that's all I hope to get from this. Here, here, here. And the use of this will be training yourself to go very fast. And on the last person that we did on this side of the group, I think Paige was on the table, and everybody as they were doing the listening stations stopped. And most everybody found something on one side of her pelvis. And everybody stopped and kept listening there. That's because everybody's finding something. In training yourself to do it, just keep moving along. You go, warmer, 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 God, that's fire, okay, and then just move on. Because you're going to come back. I'm going to do global, and then I'm going to, at some point, local. I'm going to go and do diaphragm releases up and down. And I'll get to that spot again. You don't have to understand what it is now. And the other thing, last thing that Martine asked me, do I get a sense of up, down, depth, and all that? No, I don't. For me, it's a flat sheet, and I go, this area. I'll get the depth going back to that area if it's the big needle and the big haystack. All I want from the global diagnosis is 30 seconds. 30 seconds to get an idea of something. Don't have to correlate with the patient, don't have to be right. And because I'm not going to discuss it with them, it takes all the pressure off so that I don't have to think I'm being examined. I can just do it. I demonstrated this idea at a big conference in Frauennissel, which is an island in Kempsey in Germany. It was really funny. I did this, and later on at lunchtime, one of the participants came up and he asked me, he says, they asked me to demonstrate on somebody, find something. And I was go, I don't know, 200 people, something like that. And so I'm going to find it. Maybe we agree, maybe we don't agree, but everybody always hopes that I find whatever their big problem is. So I had to demonstrate on this kid, and then I didn't have enough time to continue what I was doing. They had the next speaker on, so I didn't get to hear his story about whatever was bothering him. And whatever it was, I found something on one side of his abdomen. I said a clavicle, And then he had some other problem. Sometimes I get a sense of how long it was, and like a problem from like years ago on one of his ankles. So I said, here's problem A, B, C, and then I didn't get to finish my lecture. So he catches up with me in the lunchroom, and he goes, I want to know how you did what you did. And I'm like, what, well, I'm wrong on everything? He goes, no, I took a ski pole here, I broke this clavicle, and 10 years ago, this ankle was twisted, what you said. So, for whatever reason, Buddha, God, Lord, Jesus, whoever, chose for me not to look like a jackass in front of strangers. But it really skips the point. I don't care if we agree or not. What you find is what it is. Same thing happened to me on a much more nerve-wracking experience in China. Because I was teaching in Hong Kong for a number of years, and then I got invited to go to mainland China and explain what I was doing in Hong Kong. But the explanation was really explain what you're doing in our country. So it was for only like 20 Communist Party members.
Oh my God.
And they're not exactly a comical group either. Comedy's not one of the things that they do. So I got up and I did the same thing for a group of just 20 people that are not smiling at me, not feeling a good time at all.
You're out of your element.
Huh?
You're out of your element.
Well, no, I love being in China, and I love the idea of strange and new. But, I'm not getting any feedback, like you're smiling at me, I'm not getting that. So I said, I need somebody to demonstrate on. So I had the first guy, I just did some visceral things to show them the connection. I said, somebody's got a shoulder problem in a room of 20 people. Let me have a shoulder problem. So one person had a right shoulder problem, did a liver lift, I could demonstrate range of motion, temporary increase. He smiled at me. Then the next person, I said, I'll do the global diagnosis. And I found something, I said, your number one problem is here, don't know what it is, I'm gonna guess, probably got headaches. And I said, you had something old in the hip, 18, 20 years ago, something like that. That's what I feel. And you also can't talk about energy in China. Communist Party doesn't currently recognize that thought. So, and then the last one was they wanted me to treat somebody and fix somebody. And I don't want to do that, because that can go sideways. Maybe you don't feel better right now, and then maybe I get detained for a while. Right. So, when I was done, my friends were very nervous from Hong Kong. I promise I'll get back on task because Paul's going to do the whirly bird at me again. But my friends in Hong Kong were very nervous about translating for me in China. Because I said, this is going to be fun. They're like, don't screw up. We can all be in trouble if they don't like it. You make one of your weird jokes or something like that. Don't say anything like that. They were very, very nervous. So when I was done, the guy who had this, China is run very feudally, meaning that individuals have massive amounts of power. So they said, this guy is the director for technology for Guangdong province, which is like the size of Alaska. They said, he loves you. It was this little trick I did. And then the guy, I said, your number one problem is here? He had thyroid cancer. And he broke his hip 20 years ago. And he's a general for the province. He said, you could do what you want in China.
Wow.
And then the last one, they said, now treat, and I'm thinking, okay, great, they're going to be building statues to me. We're finished now. They said, treat somebody. I'm like, I don't want to do that. And tell my family, it's going to F up the whole thing I got going on.
Yeah.
So then they push a woman up from the audience. I'm telling my friends, I don't want to do it. We're done. So she comes up, and I thought she was like nobody, like maybe, not nobody, but like maybe somebody's wife. She wasn't like somebody important. And so she says she's got neck problem and headache and whatever. And they do like really violent HVLA, is what one of my other counterparts does. So and also she says, can I guarantee she won't be worse? I'm telling my friend, like, no, I can't guarantee she's not going to be worse. I don't want to do this. And then so she gets pushed onto the table, and I get pushed over to the table. And so, you know what I did for her? I just did an OA release. I'm not going to do anything that conceptually can get me in trouble. So I do an OA release, I just feel some little bit of movement, and you can feel the love. And she was happy. I don't know whether I ever actually did anything beyond that, but the treatment, she was happy. And it turned out she was the most important person in the room. Whoa. She was the, I don't know what the title is, but minister or whatever for all of healthcare in Guangdong province. Oh my God. So I said I've been going to Hong Kong for a lot of years, and Guangdong is right across the river. So it's just funny. So whenever I've had to do it in like a large group, it's been spot on with whatever I find, but it misses the whole point, because then everybody thinks like I'm finding good, Joe agreed with what I found. But in my practice, it's not like that at all. They tell me they got a headache, and I go, I find the hip. I don't discuss it with them. I just use this information for something else that I can treat that is going to work in a compensatory system. But someone is watching out for me, so I don't look like a jackass in large audiences. But it really doesn't matter.
Just, do you find the large audience amplifies the intention as well? Drawing on their good thoughts?
I don't know.
Well-meaning, well wishes.
I don't know. You know, I do the little prayer that George Carlin said he did before he went on stage. You know it? He said, "Oh Lord, please don't let them think I'm an asshole." And then there was more to it than that. But I do start out with that. I just want to get it done. A lot of times I'm sort of like the emissary for osteopathy. I just want to get it done, and maybe they find something interesting. And the last really big thing I did was about 400 people in Indonesia without no preparation. I thought I was doing a course, and they said, "You need to go to the university. We're going to do something." And that was great. I got it down at this point for the large group what they want to hear. But what I want them is to just open their eyes to the possibility that there's something else there. Not that I'm a magician. It's the wrong message. But everybody wants to see the trick or whatever. What's the thing? I've been asked 2 million times. What's the point you're going to press on for back pain? I'm like, you just don't get it, do you? But you got to give them something they want to hear.
That'd be pointless, though.
Pardon me? That would be the point. You know what I like about speaking? Everybody in this room has been in a class, teacher, whatever, of somebody that could just talk the ears off a jackass. Uninteresting with nothing to say. I have something to say. And if I get a chance to make it a little interesting, I find it fun. I found I enjoy it. Okay, let's talk about intraoral. A note about personal space. This is my own interpretation of this. I would have just assumed that the most sensitive thing for me to touch on a person would be their pelvis, just as speaking as a guy. Guys, we don't like people touching our pelvis, sacrum, getting around the business area. We don't go through we don't see the urologist until we're my age, and that's just never a good reason to go see the urologist. No one deals with this area. Okay, females deal with a gynecologist very early on. I think men were more sensitive about being touched. But I found that intraoral, sticking a finger in somebody's mouth, that's the most invasive thing you can do. People really are going to get upset there. So just keep it in mind. So we're going to do a lot of techniques, a lot of different ideas, but just keep in mind that people have all kinds of fears. They have issues of control, sexuality, abuse, and expression. So I'll use John Upledger's expression, and it's probably long before him, calling the mouth the avenue of expression. But whatever you haven't expressed, you're putting it in your muscles. You are definitely, it was Lou Hasbrook who said to me, what doesn't work itself out works its way in. Whatever emotions you didn't process, grief, loss, death, it finds a place to live in your body and tear up your body until you can find a way to move it along. So, intraoral for me, I'm putting on a glove, and I'm with my regular patients, that's about 20 to 25% of the people I see. And that's not for dental problems, even head and neck reasons. 1 out of 4, 1 out of 5 people I'm seeing, I'm doing something intraoral. That's how frequent I'm using it. Okay. So it's a direct technique. To talk about the idea of doing direct or indirect, the moment you're sticking your finger in the mouth, the clock is running. Do what you got to do and get out. Do what you got to do and get out. All right, some things to think about. Our theory is that elements of the face are operating secondary to that drawing that you had from Cranial 1 where it showed gears trying to show the base of the sphenoid and base of the occiput working like a Swiss watch. Well, if that's true, whatever's happening between the base of the occiput and the base of the sphenoid, the face is going to be secondary to that. That's why you really need to be able to go around the vault rapidly and do a 5-minute cranial treatment. 5 minutes. How do you do 5 minutes? You do the sacrum, and you go around the base. You get everything moving. I don't spend 5 minutes for me is an eternity. I know some of you will spend a long time, and that's very fine. But if you can move faster, I recommend it. Question? Okay, so that's our theory. I don't know why I'm showing this, but I mean, all our anatomy, everything that's important from what we did in the vault, still still continues. I'm going to do the vault release, and I divide the intraoral into 2 different sessions if I have the time. If I have 3 sessions, I'm going to do the base release. Next time I see you, I'm going to do the base and the roof of the mouth. Then I'm going to do base, roof, and floor. It's kind of like an easy formula for me. It's not what you have to do, it's just what I do. If I'm seeing somebody, I'm seeing them once, got to get it all done now, I'll do that then. But it's going to be uncomfortable. The mouth is uncomfortable just because of what we're doing. Okay. Let's start with vomer. Formed from 2 ossification centers. We're gonna treat this as a single bone. As a single bone, it's going to go through flexion and extension. We can palpate that, but again, I'm not going to put my finger in the mouth and then palpate cranial rhythm. Why? Because my finger's in their mouth. So I'm going to do mobility. Everything I'm going to do is mobility really quickly. Okay? The vomer is also subject to torsional strains, meaning you might feel some different weird things when you're in there. So what I'm going to do is mobility. This is from, these gray pictures are from osteopathy in the cranial field. This is showing that motion. Base of the sphenoid is going up. This is flexion, which means that the ethmoid is going down, and the vomer is going up. So you can think of the upturned nose. And believe it or not, there's a lot of people in my profession that will really use this morphology as a way to diagnose. You know, if they got that upturned nose, the vomer, the ethmoid must be in flexion. Really? Then all of Ireland is in flexion. This is one of the more ridiculous things that I've ever heard. There's a morphology of what you look like, and then there's the motion. Anybody see anything, have any problems with this mechanical model? I got one problem. I'll show you, but I want to see if anyone else sees what I see. How is this happening? It's kind of like throwing a monkey wrench in the whole watch gear thing. I get this. If this is turning, that's turning. I get this. This is turning. What doesn't make sense is how this interacts with the ethmoid. Are these bones just shearing along each other? I just point out as a flaw. All the models have flaws in them. You're doing crinkled eyes, John. How can this be turning this way and this bone be turning this way? It's counterintuitive. You see it?
Oh yeah, I see it. My crinkled eyes is I didn't bring my glasses.
Oh, okay. Can't help you there.
What is it saying? It's saying that the occiput is going out ahead of the...
Okay, here's occiput over here. Okay, here, and this is sphenoid bone. Sphenoidal sinus. Okay? So the sphenoid is going up. So we all agree that's flexion, right? That's our definition. If the sphenoid is going up, what's the next bone that it's if this is a clock here, if this is going up, then this is going down. If this is going down and it articulates with the ethmoid is going up. Here's your nose, here's nasion, glabella. And they're saying that because it's articulating with the vomer, which it is, that if it's turning this way, then the vomer must be going the other way. You can agree with that, right? Conceptually, you can agree with this going this way. If this is a gear, this is turning this way, and that's turning that way. What I can't agree with is the articulation between ethmoid and vomer. I'm just pointing out to you that all the models are flawed. So we're going to palpate an experience, which is flexion and extension. We're going to palpate a mobility.
Doesn't all that movement largely depend on where the center of the axis of rotation is, though? I mean, as far as like the bones themselves, the weight, you know, the shape, all that stuff. So I kind of accept it. I don't really understand how I would even question it. I guess I don't even know if it's a question.
It sort of is. I'm going to dig it out for you. Okay, my observation is between this bone and that bone. That model does not make sense, no matter where the axis of rotation is.
So is there more of a sliding surface between those, the ethmoid and the vomer, and more of a teeth or serrated dragging?
It hasn't been elucidated for me, and I don't know, and I've not investigated. You know, I just want to point out to you, I like to be a free thinker myself. So there's a lot of pablum that I get told. You know, the moon's made of cheese, and okay, the moon's made of cheese. Just think for yourselves, that's all.
Did you say you get there's a lot of Pavlov?
Pablum is like pablum for the masses, you know, just stuff they're feeding stuff and telling you. It's a word. Pablo.
Baby food.
It's,
Is that what it
Baby
means?
gruel.
Yes,
Yeah.
baby drool.
I like gruel. I like that idea. I've eaten.
Is that drawn accurately or drawn?
I don't know.
Could be
I don't know.
made up.
I want to give you what my academy gave me and said this is all true because I said it's true.
trust the forces.
Trust the forces.
Why didn't they do?
Okay? And I'm going to show you something else that another one of my friends who's smarter than me, an observation he made, and I'll share that with you this morning actually. Okay, so I'm going to start here with the palette, and I can't draw, as you already know, at all. So all I can do is like stick drawings. If I'm going to call this where the vomer is going to be above this part of the palette, things that I've seen is I've stuck my finger in the mouth and I felt like a divot up there. We could theorize, cranial people will theorize that the vomer is inflection because of that divot. Okay? That if the roof of the mouth here is maxilla and the vomer is on that intermaxillary line, it's above it. But that if it is inflection, prefers to go inflection, that it's going to draw that palate up. That's what I've been told. I'm not looking for my treatment to actually change that morphological structure radiographically. But on a small level, you can change it and make increase people's airway a little bit. But this is the idea of the vomer inflection. The treatment's going to be not too bad, what we're going to start out with. And then things will get more complicated. This we could theorize that the vomer's in extension. You with me on this, what I'm trying to show with this? If I go backwards, and I say, if this goes up, then it has to draw the maxilla up. If this goes down, but whatever you see, whatever position that you see morphologically, they are continuing to move and go through flexion and extension. And the mouth is very movable. Other question someone hasn't asked me yet, am I going to take devices out? I don't take devices out. I've had kids with palate spreaders. If they got something that comes out, it's removable, fine. If not, I'm working through whatever they got.
But if they have something that you can't take out, you
I'm mostly not.
because you want to work with whatever.
Whatever they're dealing with in their life, I'm working through that. We can theorize about the idea of a torsional deviation. And I've had people instruct me on some really complex ways to deal with this. And I think the treatment is actually easier. But let's just say, could the vomer be deviated? This is one idea of a torsional deviation with extension. Yes.
What's the bone doing?
What we're saying is it's either twisted or it's somehow slightly off of midline.
And so you would feel that in the mouth.
Yeah. Well, sometimes when we go through the range of motion and push that, you may feel it takes an odd twist. I'm just trying to theorize what might be. What I can tell you, I'm not standing next to that radiator anymore. I'm standing here for a minute. 10 degrees cooler or whatever. So, can you see? Am I blocking anybody? So, it's just a thought process. When we studied radiology in medical school, Dr. Meals, who tortured us endlessly and mercilessly, said, what percentage of people have a septal deviation? Everyone is what he said. If you want to read that MRI and look at someone's septum, their nasal septum that joins with the vomer, he says you can always read that as a deviation. There is no one that's exactly a straight line, and so it gets read. First of all, in the States for sure, things are over-read because everyone's afraid of being over-sued. So they always say things are a problem that might not actually functionally be a problem. So we don't see that people that are straight anyway, but whether it's really deviated is another matter. This I'm just trying to show the representation of what it might feel like in flexion when you push them up and take them through a range of motion, which is what we're going to do. We're going to do mobility, and we're going to do it very rapidly. So how am I going to do it? Put a glove on, and I can't really make pictures to show. I'm going to try and avoid the premaxilla. The premaxilla is where their teeth are inserting into the alveolar processes. So I'm trying not to touch their teeth. Sometimes it's just not, you just can't avoid it because they have a small mouth. I got sausages for fingers. So, but if I can, in a perfect world, I'm trying to get onto that intermaxillary suture on the anterior aspect. And I'm going to push straight up. Oh, right, this laser's not going to show here. I'm going to push straight up to the vertex of their skull here. I'm going to go on, off, on, off, very fast. Nothing to do with cranial rhythm, just mobility. If you think there's a cranial rhythm happening, then it's happening. And mobility will assist its ability, enable it to move easier. So again, I'm not trying to feel for how's the rhythm in their mouth. Open your mouth and stick my finger in. The first thing I do is vomer. Reason why I do it, I do this as a protocol. I go step A, step B, step C. That way I'm not going to forget something. I'm always doing the same thing, and I'm saying, how is the movement while I'm doing the treatment at the same time? And I do this in a certain way that I think is most comfortable for people. So let's take a situation where you stick a finger in people's mouth, they're all upset. So the first thing I want to do for you is something that's not going to be too mentally unbalancing for you. This is not painful to do the vomer, and it gives you a chance to make that contact. You know, the first time the dentist starts working on you, we all have that experience that they're going to hit a nerve and they're not going to stop when I ask them to stop. It's a little bit of that same kind of experience. You're sticking it, so I tell them, I'm going to do this, all I'm going to do is touch right behind your teeth, you're going to feel some pressure, if I see your hand go up, I'm going to stop. I set up all those rules, and I go to the vomer and I do a little bit of something, and I immediately come out and I say, is that okay? I do that all the time on our first date. With children, no, I torture them because it doesn't matter. Because I'm going to do my technique anyway, and sometimes I have to have the parents hold them down, and then I just do it. So there's no niceties there. Hey, little Freddie, how you doing? I'm just going to get it done. But with adults, it's the truth. With kids, I'm just going to do what I got to do. With adults, no, you got to walk it a little bit. You got to walk it back because maybe it might not come in to let you do the treatment you want to do, and there's a tremendous fear. So I do a little bit, and I go straight up, off, on, off, on, off, on, off. It's the first thing I'm going to do. I can force flexion. I can't force extension. You're going to see in cranial books people telling you that you can, and I'm going to tell you it's not practical, because you'll see in other pictures that I have further along. This doesn't work here. The hot box for a moment. This space, my finger pad is like here. My finger pad's almost going to the crus, okay, which is going onto the soft palate. So you don't have all this space to dance on. So when I push here, I'm forcing flexion. If I'm going to go back here, this is the line between palatine bone and maxillary bone. I'm already going to be on the palatine bone. So I don't really realistically have a choice of doing that. I have a choice of on, off, on, off, on, off. And I'll push it 5 or 6 times really quickly. If I find something that feels weird to me, that I'm pushing up the mouth and it feels like it's twisting, I twist my finger and I just follow it. That's how I deal with torsional strains, on, off. So first let's just do a compression distraction. We did this in the cranial 1. Okay, let me go back. Okay, let me have, what you need is you need a cup that is only going to be for putting fingers in the first time. So that way you have a cup of new water. No re-dippers, no double dipping a chip. Okay, so you need a cup of water, and I'm going to demonstrate up here. Let me have somebody's head right up here. Lay down this way, anyone. And I'm going to show you what I do for the vomer. Need a cup of new water. It's very tolerable. Head up there.
Did you bring water?
You're supposed to get the water.
Get the water.
Oh, there's a.
I've been drinking out of both of them, and who knows where I've been. I haven't.
So you're actually touching the palatine bone?
I'm touching the maxillary bone.
You're on
The vomer is above that. In my office, what I had is much more, after doing this for a long time this way, I don't know who showed me, but I would take a little piece of toothpaste, smallest piece, rub it on my fingertips, and then wash it off. It's less gross than this. What's funny is I had a kid one time, and I said, all right, I said, you might taste some toothpaste. I put it on, I wiped it off. I'm doing the technique. He goes, toothpaste is still on there. And I said, no, it isn't, little Johnny. It's not on. It was a big chunk of toothpaste. Okay. With my other hand, my free hand, I'm always doing a frontal lift. If there's something I can do, if I have a student with me, I have them do like an OA release at the same time. it's always good to decompress things. Keep in mind, people might get a headache from me working on this. But why am I doing it? I'm doing it to fix a problem. I'm doing this to people that have full-blown migraine headaches on the table. Okay, I'm not trying to tell them to bite the bullet, but I'll keep going unless she stops me. Who are you going to do this for? Let's just talk about region. Why would you be doing intraoral? Reasons for doing intraoral. Give me one. Give me one reason.
Headache.
Headache. That's number one reason. Give me another reason.
TMJ.
TMJ. Give me another one.
What about,
All the other stuff you did didn't.
Back pain, neck pain, amblyopia, strabismus. Amblyopia is a lazy eye. I've been able to help and correct a lot of lazy eyes. Never a strabismus. I've tried. Strabismus is crossed eyes. Maybe they have a hearing problem, tinnitus,
vertigo?
vertigo. It's another reason. Give me some more.
Earaches?
Earache.
Dizzy?
Yeah, I mean every head and neck reason you can
Nausea?
think about it. Yeah, you can think of. What'd you say? Sinus, biggie. Yeah, biggie. Sinus is tricky. We're going to do a whole protocol for sinuses. That's a tricky complaint. So I'm going to do a frontal lift while I'm doing this. I'm going to tell her, all I'm going to do is put my hand behind your teeth. If I see that hand go up, I'm going to slow down. Is that okay? She's going to go, yes, Steve, that's fine. That's wonderful. I'd like you to do that. Okay, so you're going to open, and I'm going to go right behind her teeth. Close. Let your mouth close. Close. Relax. Close. You're not going to hurt me. Okay? Now, from here, I'm not going to feel cranial rhythm. I'm going to push up just in front of her vertex. On, off. On, off. Up, off. Up, off. I'm not coming off her skin. I'm just releasing my pressure. Yeah, I'm just pulsing. And she feels fine to me, actually. I don't feel any problems.
What would you find?
What I find is it's hard to push it off. It feels like it releases easy. The opposite of that, and I'm just going to do that 5 or 6 times. If it's for sinus, hold on. If it's for sinuses, and we're going to get into that, I'm going to do it for about 30 seconds. I'm going to stay in there for a long time and pump because you have 4 sets of sinuses, and we're going to do that. It's all going to be. It's all in your sheets. Yes.
How much pressure?
It's ounces of pressure. It's not this 5 grams of pressure or whatever you may have heard. I'm pushing on there. If you got a migraine headache, it's going to be pulse on, pulse, pulse, pulse. Okay, and I do that first one, and then I come out and I go, are you okay? Really important to do that. Because even people that you think everything's fine in the world, okay, you start doing this, people get emotional reactions, they get a lot of things. And I also want her to close her mouth on me. She's not going to hurt me. Because I do this to kids who are trying to hurt me. I'm not, that's not not one word is that a joke. Okay? Not one word is that, I'm doing this to kids who are going to bite me. And, you know, the hardest I ever got bit was by maybe a 3.5-year-old girl, something like that. She had, around age 2.5, crawled into a swimming pool and drowned. And was clinically dead for about an hour when they resuscitated her. Kids can be resuscitated after about an hour.
Dang.
Me, after 10 minutes, they're like, yeah, we're calling this, he's done. Get the box. Kids, they can come back to life after 2 hours and working on them sometimes.
What?
So
Is
she
there
was
damage
clinically,
done after that?
pardon me?
Would there be brain damage done?
They're probably bagging.
Well, I'm gonna tell you what happened. This is a whole different thing. I'm 52 years old. If I go in the emergency room, they're gonna work hard and all that. But if you're 80 with cancer, we're going to do this for 30 minutes trying to bring it back, 45, and it's done. You're not coming back. When we see a baby come into the ER, we work for 2 hours trying to resuscitate them. And sometimes they come back with, we can't know what the deficit is. Sometimes they seem normal. This girl, I did a couple of sessions on her, a whole lot of nothing, just a piece of dead tissue. She had a G to J tube for feeding, just a lump of flesh. And then I said, well, I think I need to do some intraoral. So I didn't bother protecting my finger. Because what I do is I would take a tongue depressor, break it in half, and then I tape it around my finger. So you can make your best try, okay? Because I'm going to go in and get out. So I didn't protect my finger because she's clinically a vegetable. So I put my finger in there, I felt something, and then it's a cardinal reflex, like a vice. Okay. One step, almost using my shoe to get my finger back. Now that girl drowned at 2.5. I'm seeing her a year later as a vegetable. The next time I saw her, she was cognizant and saying mama and hungry, which is things that she was saying when she died. And then the parents went in different directions. I never saw the kid again. So you don't know what's possible. You know, you think that there's nothing there. Somebody was inside, waiting to bite a finger off, just waiting for the right guy. Okay, so I'm going to go behind her teeth, and I'm going to aim for up here. I'm just going to go, just do an assessment. Okay, and if I find that it feels like it wants to twist, I'm going to let it twist when I go up. Just on off, quickly. And then I come out, are you okay? Then the next pass, I'm going to go in and do vomer, and the other thing,
Ethmoid.
maxilla. And if you want to do what we did in Cranial 1, you can do the compression. We already did this technique. Compress for about 30 seconds, 45 seconds. You know, you're driving back here to about where lambda is, and then doing a decompression. That's the technique we already did.
No.
No, we did not.
We didn't?
No, we didn't.
Okay, we're doing it now then.
Good.
And here it goes. Open your mouth. I'm going to go in that same spot. Now some people close, let your teeth close. Not hurt me. I need her to close because I don't want this musculature all being tight, and it's not going to affect my technique. I'm going to do a compression, and I'm going to compress the vomer. Can you go, John, pick up my thing there and just go back a few slides. Just go back. It's the arrow button's left, right? Yeah. Go back, back, keep going, back. Okay, right there. So I'm going to, if you can just make a hole here so you can see, I'm going to go back and push against the sphenoid. I'm going to compress, and that's about a 45-degree angle. Here's sphenoidal sinuses. So, open. I'm going to compress. You have to put some pressure against the roof of her mouth, and the direction is back here.
What is that called on top of the head?
Lambda suture.
Her lambda is where both parietals and her occipital bone come together. Not a magical spot, but that I just want to give you an idea where I'm pointing toward. Somewhere back here, the corner of the table.
So this is the first thing you do going in?
I may or may not do this. I may or may not. It's just a choice. I'm going to do the up-down for sure, taking through flexion and extension.
Are you using
This
more
is
pressure now than you were for the pulse?
Yeah, it's a few ounces. When I feel I'm not getting anything anymore, I'll start to withdraw. I'm not doing this technique too much. I'm doing the up-down, up-down. If I can take it through flexion and extension, and I'm not having a problem, I'll move on from there. If I am having a problem, then I'll decide if I want to do this compression, decompression.
Your contact's in the same place?
Yep. Because my finger is taking up, this much of my finger is taking up at least half of her oral cavity. I'm just trying to avoid the teeth and the front of the maxilla.
How do you put the tongue depressor in if you're working with kids? Is that?
I just take a little piece of wood like this. If not, I'll just wrap cellophane around. It helps you also. And with kids,
Inside the glove.
no, not inside the glove, on the outside. Here's how you get a kid. Okay, kids don't want it done. So I had that one kid screaming, carrying on, and eventually, in mid-scream, I'll stick my finger in. That's how I do it. Because they can't stop screaming. So scream as much as you want. It's just funny. I have had the fishhook kids. You know the fishhook. You grab in here, go like this. You're trying to help them. It's medicine. It's treatment. The toughest time I had, you can sit up. The toughest time I had was with maybe he was like 7 or 8 years old. A family of autistic kids. I'll demonstrate on one other person.
Here's
Come on
the
up,
garbage.
John. Lay down. I had an autistic family. 3 kids autistic. Same mother, same father.
Oh my God.
Yeah, imagine. Coming from Pittsburgh, so it's about 6 hours away. So kids, he's get another glove. The oldest one, you could talk to him. He was around 12, I think.
Control.
He was not right. He had a lot of echolalia. Like he'd just keep repeating stuff. He'd come in and see the skeleton. Bones in the skull. Bones. Like stuff like that. The second one was probably the most intelligent one. And he couldn't stop. He scarred. His lips were all scarred from that. From lip smacking. It's a form of stimulation. And had to wear dinosaur clothes every day or there'd be a fit.
For your session?
Is this the water I'm using?
Yeah.
And they made progress over, I don't know what I saw them, 10 or 12 weeks. The last one was one step from being institutionalized. He's your view of a child that's possessed by the demon. Okay, he would come in. I couldn't have a computer out or anything because he would just knock stuff over. poke a finger in your eye. And the parents were like, we're going to have to put him in his, the parents were at the end of the rope. So the other 2 kids showed treatment, and this kid, nothing. And I said, I think I'm going to need to do some intraoral with Seth. And, you know, probably have some crosses hung up around the side of the room, do some incantations, because he's going to take my finger. And I told the father, who was big, like a linebacker big, I said, you need to help me with this. And I had him spread eagle over the kid like this, and he was. If you've ever seen The Exorcist, everything except the green poop coming out. Okay, I said, I'm going to need your help. I said, you can't be a sissy about it. I'm going to need you to lie on top of him. So he's doing his routine. I got him in mid-scream, and I had the thing here. And this is a kid who's not communicated except grunts. He could take a can to his mother and go, which meant open this for me. And then after that, the next time I saw him, open, close, relax, and I'm just going to go straight up and down here. The next time I saw him, the next week, I'd have to get ready. End of my day, I want to see Seth last, because I got to go home after this. Get a drink or something. You know, I can't deal with the rest of the day. So I say, and I come out, you okay? It's just straight up, down, open. Here's the compression, decompression, close, close, let it close. Here's, you're not hurting me, John. Let your jaw relax. Let it relax. They come in a week later. You know, the one kid with the echolalia, he was showed a lot of improvement over the course of treatment. The dinosaur kid stopped wearing dinosaur clothes and stopped lip smacking. And the last one, I get myself ready, and mother goes, you know, it's the strangest thing with Seth. And I said, what? She said, Seth, come in here. Say hi to Dr. Sanet. Kid who's never spoken a word. Hi, Dr. Sanet. She said, count for Dr. Sanet. 1, 2, 3. Counted to 20, said his ABCs. Never spoken a word. Best part of this, mother said, you think it has anything to do with what you're doing?
Yeah. Oh, no. Nah.
And I said, 'cause I just couldn't wait for that line, are you doing anything else? No. I said, is it possible you could give me an ounce of credit for what's happening? And then I found someone else for them that I think it was tough for them traveling. I found somebody out in Pittsburgh they could continue with. I don't know, maybe it's not me. Maybe, you know, people that have disabled kids, they're searchers, man. They're doing lots of things. I don't know if maybe
drives don't spontaneously change.
Yeah, it's just, you know, if you make a mistake, for sure you're getting blamed for it. You know, then the kid talks, he's never spoken a word. You think, you know, crazy people. Okay?
So can I ask
So,
a question?
yeah.
The first one is the pulse up and down towards this.
Has nothing to do with cranial rhythm. On,
Right,
off,
right,
on,
right.
off, on,
Second
off.
one long slide.
It's,
Towards
this is what
Linda?
I'm doing. I'm from that same position, I'm just going down 45 degrees, more or less down to where his head meets the table. It's
long slide.
like I'm compressing a sponge until I feel it doesn't want to go anymore. And that could be 30 to 45 seconds as a rule. Longer than that, no. Just don't be that long in the mouth. Okay? And then just unpressure what you're doing. Because how are you going to distract something? How are you going to come off the roof of his mouth without coming off the mucosa? So you're going to release all your pressure, be short of coming off. So you're not going to come off. And I'm not doing that technique
You're
so
not
much.
actually sliding, right? You're not
No,
actually,
not at all.
Not a slide, I don't think.
There's no
the
electric slide. Okay? Simple. I want the first thing that I do to them to be very tolerable and very short duration. Because I'm going to do things to the mouth that are going to be short duration, extremely unpleasant.
What's the waterfall?
Water, it's just easier to work in somebody's mouth rather than having a dry mouth. You'd think it's easier to work in the mucosa if you're going to stick to them, but it's more uncomfortable for them. So the water, I just find it easier, but if I am in a place where I don't have water and I work in the third world a whole lot, you know, I just do it without.
Oh, what is the axis of motion for the
Maxilla.
maxilla?
Yeah. If I wasn't clear about that, cranial motion, it's this is external rotation. This is, you know, it's all the bones here because it's all going to fall apart, but like that.
Don't worry about it, it's small.
Won't miss it.
Oh, it's right there. The bomber. Okay. No.
Since it gets out there.
I'm leaking. tissue? You got
I think there's some out here.
tissue?
Clear out.
Thanks. I apologize.
The trash is right on the side of the table.
Oh, that's good to know. Gotten to the stage in life where something drops, I don't have a reflex to pick it up. I first look at it and say, do I need it? I mean, it could be that I'll fall and I'll be near it again, in which case I can just pick it up then. Sad but true. Okay, so the axis is this. This is external rotation, this is internal rotation. Can you feel that if you stop and stay there? Yeah, I think you will. But for me, I'd rather do the mobility because in the normal session, not the first person, not the first time we've done this, I'm going to do vomer, maxilla, palatine, and then I'm giving you a little break. And that's could be a minute to a minute and a half. That's a long time. And then I'm going to do floor of the mouth. And that's going to be about a minute to a minute and a half. And that's going to be painful. So I'm trying to eye that out of my whole session. So can you spend longer, and if they're tolerable? Yeah. Just realize they're uncomfortable the moment you have your finger in their mouth. And the benefit, the best benefit, in my opinion, is increasing the mobility. If the mobility is there, the tissues are free to go through motility. If there's no mobility, it has a tougher time. So I think the question was, is it doing something else like this? I don't palpate that, and cranial people aren't writing about it, but is it possible? You know, I like to think about things rather than just saying yes and no to what people have told me. I don't see how this motion is going to be so possible, really. It's out there from the face, so certainly it's free to do more of this, but it is connected backwards to the face. So I don't know anything like this. It's the internal and external rotation.
So can I just ask you, the external rotation is with respect to the posterior aspect of the mouth?
Posterior aspect is going lateral. The anterior aspect is going medial. That's the external rotation.
Okay.
And there's also this a little spread.
Yes, but mostly you're looking at this. Okay, next let's look at palatine bone. Palatine bone. We're mostly going to be looking at this plate here. Palatine bone has a lot of freedom in it to move, and you're going to find, if you felt some motion in the maxilla, generally speaking, you're going to feel, I think, more motion than palatine. And people are kind of sensitive to it because of where it's located. And give people the pre-warnings. You might feel something here, there, whatever. My motion, again, is going to be all mobility. As we go onto the soft palate, this area that's called the crus, the cross here, you should be able to identify on every single person in this room. Everybody should be able to feel that speed bump, okay, that landmark. Greater palatine foramen, this we should feel in everybody. This is, what is this here?
What is what?
Because we're gonna mobilize this on our last day. What is that?
That's the horns of the
It's
sphenoid.
the bottom of the sphenoid. So when we said that, originally we did beginning cranial, we said, well, we can only touch the sphenoid bone from the outside. Well, that's not true. A little bit of effort, you can start pulling on things back here, and that will be probably one of the most painful things that we'll do, is a mobilization for that, but it's something they should know how to do. Once in a blue moon. When I do the more rare, stranger, extremely painful techniques, it's because the other stuff's not working, or I've gotten to that level and the complaint's the same. I don't ever think of, let me go in and pull on somebody's pterygoid plate and see how that's going to work out for them. At first, do everything else, and first do everything else. Some things to mention about it. This is from Osteopathy Cranial Field, all these grayed out pictures. There's an orbital process here that people make a big deal of in the Cranial Academy. They do anyway, because the trochlear nerve goes over that, and they say that process. Better to see it here. They say that it's this here. I don't know why it's the same orbital surface here, but the trochlear nerve goes over this little doohickey here. And in the Cranial Academy, in osteopathy and cranial field, they write down that they think it's, Dr. Sutherland theorized that it was a speed transducer for the trochlear nerve. Okay, meaning that it modulates tension along that nerve and does something. Again, I only want to say it to you because it's said in our academy, so you can be familiar with it. I don't really buy into that. What's the trochlear nerve do? Yeah, that's what I thought. So it's one of the 6 eyeball muscles. There's 4 recti muscles, which all just pull the lateral one pulls the eye that way, medial one pulls that way, and the superior. This is the superior orbital muscle. So I think it rolls the eyeball down and out, or rolls it up and out. It does one of those things. So if it actually is doing something to modulate that extraocular muscle, my Steve Sennett brain problem with that is, well, what's modulating all the other eyeball muscles? Because you have 6 of them, not 1. But you'll hear that from Cranial Academy.
Why is it named trochlear if it has something to do with the inner ear?
Huh?
Why is it named that way if it has to do with the eye and the inner ear?
Because my mom thought that was the best name that we should use for that. I got no idea. I had no idea. Trochlear is probably, if someone here knows Greek or Latin, it probably means something having to do with some process or projection that somebody thought about. I have no idea. Unless you're thinking of cochlear.
Yeah, probably.
Going with the cochlear or trochlear.
Right.
Got a little bit of wine in that cup there. Okay, so, yeah, I don't know. Just another view. It is a paired bone, so what's it going to do? Internal and external rotation. Are you going to palpate that? I don't think so. Can you do mobilization for it? Yep. This is a picture. Must have taken it out. Well, there's another interesting feature about the top of the palatine bone. Is part of what? What other part of your skull do you think it's part of?
Sinuses.
No.
Or not.
Or what?
Or not.
Or not. It's also part of the orbit. So sometimes, not a lot of times, but sometimes I'll poke on this and people get a pain right in their eyeball. So I've just said, you might feel some pressure in your eyes and whatnot. 7 bones that make up your orbit. So let's do it. Frontal, zygoma, maxillary. Okay, that's 3 to 7. And there's 4 others. What are the other ones? Palatine's 1. Sphenoid is another one. You got 2 more.
Lacrimal.
Not the nasal, but the lacrimal. That's one usually gets forgotten, and we're missing one. Ethmoid. Ethmoid. Yeah, so those 7 bones make up your orbit. So this is the smallest piece. It's a little triangle shape. But just the same, did you ever get 1 grain of sand in your eye? So when you're poking cephalad, which is what we're going to do, sometimes people will complain about that. And your patient who's walked in your door with the dark glasses doing the migraine shuffle, it's going to be uncomfortable for them. But it may be part of their cure for helping them. So here's about the orbital process I already told you. So here's what we're going to do. The treatment is going to be, I'm going to go cephalad, lateral, and then I'm going to let it push me back from those 2 motions. So I'm going to take my finger and I'm going up, lateral. This is going to be 10, 15 seconds at most. Then I'm going to, when I say push me back, I think Paul asked me before, what do I mean push me back? I mean, I feel that I'm not going any more lateral. So I'm just going to relax my hold, and when the tissues start expanding, which they will, I just go back with the tissues, and then I'm going to go down. And I'll do each one twice. Twice isn't a formula, it's just a habit I've fallen into. This area, more than the maxilla, as a patient complaint, people will say they feel burning. Let's say they feel burning, their eye starts tearing. Why do you think that is? Thank you for that. Thank you for sharing that. You're not far from the
It's the answer.
From the what?
The silence is not far from the answer.
I like the way you think, Ray. You're not far from this greater palatine foramen, and we're going to use that in regards to sinuses. So you're really about 1.5 centimeters away from the pterygopalatine ganglion, also called sphenopalatine ganglion. It's the same ganglion. You'll see it written both ways. So when you start playing with the tissues around here, people will get an autonomic response. They might start tearing. We're going to use that when we start doing a specific protocol for sinuses. We're going to irritate the sinuses to get things running. So it's not too an uncommon thing. Let's see if there's something else I want to say before we go to the table with it. Okay, so let me have somebody on the table. Not all at once, just form a line.
So what's the mobility of this is the right side.
The mobility is that we're gonna push it up, lateral,
Up,
back and
lateral.
down. It's just up
Yeah.
and then carry it lateral, let it come back and go down. Cephalad, lateral.
Can you show that, Ray, what he just showed you?
I can't. Not on
This
the
is,
model.
this is, right, facing this way. So it's, if I'm on this side, I'm going up. Here it is, right here. Okay, I'm going cephalad, and I'm going lateral, and then I'm letting it push me back, medial, and letting it push me down, and I'm never losing contact with it, and go up, back, and do it again. And you will feel this move. You should feel it move as an operator, and the patient should feel love. That's what you should feel, John.
I feel it already.
I knew you did, my brother. Let's keep this a secret between you and I. The other people that are going to post it on Facebook in this room. Okay. Now I want you to start again from the beginning. Vomer, maxilla, palatine. What happens if you went and did it the other way around? I don't think it makes any darn difference. But in this case, it's good to fall into a pattern, so I just never forget to do it. Okay, so, but here I'm gonna skip past it. So I'm gonna do Vomer, 1, 2, a couple times. Maybe I'll do the compression, decompression. Then I'm gonna do the maxilla, lateral, off, lateral, off, lateral, off, lateral, off. And then you're gonna go over that speed bump. Okay? And everybody's got it. Everybody's got it. Once I go over that speed bump, the pad of my finger is covering the whole palatine plate. If you go back further, you're going to go into the choana, which is the hole up to the booger locker. Okay? And then that's going to cause a big problem. So once you've gone up across the cruise, well, that's what it is. Once you go across the cruise, you are there. No need to go any further. And some people will have a real problem with this. And I haven't had a patient that I haven't been able to do this on. Close your jaw. Close your jaw. Relax. You say relax, people won't. So you got to go like this. Shake him up a little bit. He's still trying to preserve my finger. I don't know why. For the life of me. There we go. You're not hurting me, John. Not at all. Now here comes up. This is cephalad, and this does not want to go.
You're on the left or the right?
I'm on the
his.
right window side. He does not. It's not moving hardly at all. Didn't expect it because he's such a happy guy. No, I'm done fighting with him. I'm just going to go lateral. I can move lateral. I'm just not getting cephalad too well. Now I'm going to let it push me back. Come back medial. And then down. You okay, John?
Mm-hmm.
Okay, going cephalad. I'm getting a little more on the second round. Lateral. Pushing back medial. Medial is just a relaxation. And down.
Is cephalad first before lateral?
Yeah.
Lateral and then
Yeah.
cephalad?
No. You want to go north
Up?
first.
Okay.
Because it's going to make it a little easier to do the lateral part.
Okay.
What's
And then-
this response about? Yeah.
That's how he shifts gears, John. He's got one
Downshifted.
gear, yeah.
Comment. What did you feel?
It's an
Or
old manual.
good, bad, indifferent? What did you feel?
It was, I mean, I could feel it moving. I could feel it laterally moving.
Okay.
Other than that, just relaxing.
Okay. Was it jumping for dramatic effect, or did something make you do that?
It's just a discharge.
Okay, good.
It was automatic.
Good. You might want to watch yourself down there. It makes you kind of close to the field goal. So this is the way I do it. My finger's in here. This is what I'm doing. I didn't do the other side on him. I go up, lateral, back, down. Do it twice, and then I just go. While you're already there, just go right to the other side.
When you do down,
Cephalad, lateral, and then I allow the tissues to just relax and undo what I did, and I just drift backwards, medial, and then I just relax. I'm going back, caudad, that way, caudad. to the feet.
You're just.
There is no,
backing off
down's a bad word. I'm going cephalad, lateral, medial, to the feet. No down, no posterior.
You're still holding cephalad while you're going lateral.
Yes, holding cephalad, we go lateral.
Booger locker.
Try and avoid
The booger.
the booger locker.
What happens?
Unless you're an ENT, it's just gross. The pressure is going to be, this is a description of what we're doing, and then the easiest way is going to be for me to show you with this guy and on a patient. I'm going to put pressure inferiorly between the teeth and the tongue. I'm going to show you how I was shown, and I'm going to show you how I do it, which are two different ways. The musculature that's under there, you have the digastric, mylohyoid, genihyoid, and stylohyoid, and then all the layers of fascia in between. So I can't say it's a release for a particular one, it's a release for all of them as a group. Okay, in the bottom here. It's not cranial bones, but it's fascia, it belongs in the cranial pores. We used to have to memorize in medical school, as odd as this would be, a professor would talk to us, if someone got stabbed up here under the chin, which muscles are you going through, in which order? Little insight to his life. These muscles are all involved. This is going to be very painful. When you start breaking fascial bonds, people will all tell me that I got long nails. I don't have any nails. But it's going to feel like you're cutting, okay, when we do this technique. It's going to be very painful and very brief. People can do high pain briefly. They can't do it for an extended period of time. Once I put my hand in here, I'm going to put my finger in here. I'm going to go back and aim towards the angle of the ramus. I'm going to go posterior. I'm going to go inferior, a little bit lateral, and I might start a tad posterior. And I'm going to ream around to the mental symphysis. And then I'm going to do the other side, and then back, and then back. The second pass I'm doing it, I'm always doing it harder. Always, always, always. And they'll always say that it was easier. Because you're breaking the bonds, you get the change, you're going to see it right then. When you're going around, you're going to start at the angle of the ramus, and you're going to go around. You're going to hit something that is a submandibular gland. It's not a restriction, it's a submandibular gland. So I'm going to pick my finger up, go over that little bump, and then go back down. There's another one underneath the mental symphysis. I'm going to go up and push straight down. Okay?
Those can be damaged permanently. I heard someone, I know someone that knew another practitioner that actually thought it was a restriction, dug it out. Can't remember if they have constant dry mouth or constant. I think it's constant. Yeah, it's just such an irritation.
I'm sure they got constant pain if someone tried to dig it out. So, yeah, leave it. They need it.
Leave that.
And
Which glands are they?
you have a parotid gland here. You have a submandibular gland here, and one under the mental symphysis. So you have, 1, 2, 3, 4, 5 on the other
So
side. But you're going to feel this here. Just go over it.
Are you irritating the lingual and those hypoglossal nerves, or are you just
The lingual nerve,
irritating the...
probably going to be irritated. Probably going to be irritated, but I've been doing it for a long time. They'll get over it.
Whatever Santa touches.
Anything my wife tells me, you'll get over it. Whatever it is in life, she'll say you'll get over it. Lingual nerve is coming off of. Where's lingual nerve coming off of?
cervical plexus, the communication
Coming off your
branch, and it's a cranium.
It's coming off your cranial nerve 5, lingual nerve. Lingual nerve does taste in the back, posterior third of your tongue. Anterior 2/3 of your tongue is chordae tympani, which comes off of cranial nerve 8, cranial nerve 7, chordae tympani, I think, 7 or 8. Anyway, are you irritating it? Probably. Hypoglossal nerve, that's back at your brainstem. So we're going to do something that's going to irritate the tongue and the tissue around it. But the irritation should pass. If you extract somebody's gland that should have been there, yeah, that probably doesn't pass. Okay, so let me have somebody at the table. I'm going to make one pass, because the thing with this, if I do it twice, the next person's not going to have much to get.
You want to do it?
It's
You haven't
okay,
been a
you
demo
can do it.
yet.
You do it. What's that?
You haven't been a demo yet. Go ahead.
Are you sure?
Yeah, absolutely.
I'll do it.
Yeah, I volunteer. I always like to know. I want to know.
No.
Do something that
Get on it.
I know what's supposed to.
I
You can't recognize when someone's doing it wrong, so I just do something with someone and the next person says.
Any Caddyshack fans here?
Of course.
Caddyshack?
Yeah.
You have to be over 50 though.
People that are our generation, I get them on the table, I'm going to do something. I know them already. I go, oh, Billy, 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 Billy.
Can you talk us through how where you're going exactly? 'Cause I'm
Oh,
not
I'll
sure.
tell you.
Okay,
I'll tell
good.
you exactly where I'm going.
Please. I'm
Train is
waiting.
leaving the station. Okay? This is the way I was taught to do it, is to take this finger and put this, I'm going to do everything right-handed, because I'm right-handed, it's easier for me. But I was taught to do this, take this finger and put it on the angle of the ramus. Take this finger and bring it to that finger on the inside of her mouth.
Sorry.
Okay, and use this as a guide. It escapes me now what the word is. There's an auto something. The fact that you know where things are in space when your eyes are closed.
Proprioception.
What? No, that's a general term. Epicritic touch is you put your hands in your pockets, you know it's keys. That's epicritic touch. There's a word for that.
Stereotype.
Huh?
Stereotype.
Stereotype. Stereotype is what we think about you and all your people. And you have stereotypes about our people. So that's not it. It's not proprioception. Proprioception is a general term. There's a word for it. Auto something or other. The fact that you know about. Did I hit a nerve there? Relax. You know, when I was in, I must tell you this briefly. When I was in Saudi Arabia many years ago, I'm spending a lot of time in the Mideast, and I talked to my host there, who I became very close friends with, about stereotypes. And it was really funny because he has all these stereotypes, and he asked me about Chinese people because I go to China. And I finally said to him, after having to get all these things that he was thinking that was really far off the reservation, I said, you know, we have stereotypes about you people too. And he goes, like what? You know, my friend's Saudi. I said, nothing good. And he said, what is not good? I said, well, let's talk about stereotypes. You know, you believe what you believe about Chinese people because you saw some misinformation on the news. I said, generally speaking, the news from Saudi Arabia is not nice. So we had a lot of healthy discussions. So, no, it's not stereotype, and it's not the other thing. Anyway, so this is what I was taught to do. Bring this finger to this finger because of that touch, that you know where this finger is and use it as a guide. I found that to be completely unnecessary. Just go on tissue tension. So this finger dried off a little bit now. Now you're going to have to wet this finger, because if you don't, now you're going to just cause a lot of irritation that is not because fascia is burning, because you're starting to tear the mucosa. Okay? I'm not going to tear anything, but it's going to feel terrible to you. So I'm going to use this finger because it's just easiest for me. I don't care whether you use this one, it doesn't matter. This is easiest for me. So I'm going to ask her to open. I'm going to put my finger between her tongue and her teeth, and I'm going to aim for that that angle of the ramus. If I can't get there, so be it. I'll be a little bit anterior, but I really want to get to there. Okay? So now I'm going to tell you, just relax your tongue. Relax your tongue. Sometimes people can't cooperate, so I tell them stick the tongue the other way, relax, stick your tongue out, and I misdirect them a few times until they stop whatever it is they're doing. Now I'm right between her teeth and the tongue, and I'm going to put a finger down. If I see that hand go up in the air, I'm going to stop, okay? Mm-hmm. And I'm going to take you right to the white light. Probably not cross you over, but bring you close.
Are you above the flap of skin that I don't know the name of, or below?
The frenulum
Thank
is
you.
the frenulum. It divides in a vertical plane, so I'm not.
Not this one, the one that runs along the inside of the dog.
I don't know what even name to give that. So there's not a flap. The flap is going to. I'm going to hit another frenulum up front, and there's a frenulum between your tongue and the other. So I don't know what that is, but I'm going under that ridge. I don't know it as the flap of skin, but maybe there's another name. I don't know it. So whatever ridge that is, I'm going to go underneath the angle of the mandible. Okay. So
Okay.
from here, and I get relax. Okay, here comes. Now I'm gonna. The only thing I can describe this is reaming. I'm gonna go down, and I'm gonna go caudad and lateral. Open, open. Okay, relax. Okay, here we go. Now I'm gonna come up because there's a gland that's supposed to be there. I'm gonna go around, come up, go into the mental symphysis, and I don't have too much room here. And done. That's one side. Now I'm going to do the other side this way, which is not at all how I was shown to do it. I'm just too lazy to walk around the table. Okay, here we go. And come up over the gland, push back down, mental symphysis, and down. Nice, right? No, I'm good. I'm okay. I'm okay. As a matter of fact, it kind of turns me on.
Yeah, the
So,
watch is,
I'm letting her, hold on, I'm going to let her, if she stops me, she'll stop me. But sure of that, I'm going to bring her right to it. I can see it the whole time. I can see this look. The look we have in joyful moments and bad moments. Okay? I prefer to not have her actually stop me. But you have to respect the stop. Okay? Take her right to it. And I'll go 1, 2, 1, 2. Very quick. This release lasts. If you're doing this week after week on people, you're not doing it right. Okay? If you want a formula, do this now, look at it a couple weeks from now if you've done it. Okay, if you're doing the 3-session model, first session I did cranial base, next one I did cranial and roof, third one I did cranial, roof, and this, and pterygoids, everything, and then don't look at it for a couple weeks, 3-4 weeks. If you're having to do this twice a week, 3 times a week, and I've had patients ask me to do that, that's just psychological for not benefit. Just I've had patients, you need to do that, you need to keep hurting me or whatever. Well, I'll hurt you. It's not going to be beneficial.
What do you do it for? Like, what kind of things would someone come in that you would
This is, as far as reaching, it's this. It's a protocol for this. Okay, you're telling me that you have headaches, they haven't changed from what we've done. Let's do intraoral work. I don't do floor of the mouth because you have pain here, you have something going on in your ear, something in the eye. You have something
here,
neck, head, and I haven't gotten a result for you. I'm doing everything to the roof of the mouth, everything to the floor of the mouth, and something to the pterygoids on the side. I'm doing an oral treatment for your head, neck complaint, anything you want to name. What's the other reason to do it? The other reason to do is on global diagnosis, you feel that there's some tension here, it hasn't been addressed. But I'm not doing any one of these techniques. We're going to do a separate category for the sinus, that if sinus complaints, sinus is what you're complaining about, I'll do a separate set, which you're going to learn, and I do that combined with lymphatic treatment to get all the fluids moving. Okay, so let me have one other person. Let me do it on somebody else. Sure.
All of us are jumping on the table.
We all want it. Yeah.
Pardon me?
You were presenting the wrong word.
Stereo? Yeah, the word is stereoagnosis.
There's like 4 of us that want to get work done by you, so who wants to?
Hisham just found the word. It's stereoagnosis, which is your ability to know where things are in space.
Stereo?
Not stereotypes.
They were close. Both had
You were on
stereo in
track.
it, so.
You're on track.
Well, that being fingered. Stereognosis.
Ignosis.
I knew it was a complicated word somewhere. Okay.
Still not clear on where you're
Ready?
going. I'm still not clear on where you're going in there.
Yeah, you're a bit tense too, so this should be a lot of fun. Okay? Just relax. If I see that hand go up, I'm going to stop, okay? You going to open? Okay, let your tongue go to the other side. Relax, do nothing. Open, 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 close, relax, open, open, close, relax. Okay. You alright? Okay, here we go. Alright, okay. You okay? Alright, here we go. Open, open. You want to do the other side? Relax, open, open. Open.
I'm fine.
Me too.
Yeah. It's painful.
When she stops me, one thing I don't do is this. When she stops me, don't fly your hand out of the mouth. You're going to set up a whole scenario where she now believes you didn't expect it, you're not sure what you're doing, and it makes it worse. So I see the hand go up, and it went up twice on me. My mistake, because when she went up first, I should have been a little bit lighter, but I wanted to see how close I could go. So I'm going around, the hand goes up, I ease up the tension only a little bit. You have to realize you're crossing over from this is terrible and really painful to I can't take it anymore. There is no space where this is really enjoyable. The whole thing is uncomfortable. But there's that spot where you just cross over, so I just bring it back. And I stop. You okay? It's important for her to hear the words. Yeah, okay. Okay, then I go back at it again. Don't fly out of the mouth like that.
It feels
Yes.
really good after.
Me too. Let's have a cigarette together. Okay.
Could you show us on the
Yes.
model
Yep.
where you are?
Yep. So, where's the jaw?
Right here.
Sure.
This is exactly what I'm doing. Taking my finger between tongue and teeth, and I am going mostly inferior and lateral, but I'm telling you I'm going a little bit posterior. A little bit posterior. The posterior makes a big difference as far as placement. Okay, so I'm going down toward the table. My friend did this on me after the tonsils, and it was, I didn't think I could get through it, the treatment. I'm going to go down. You're going to feel something that doesn't move. I come up over it. I go down again, a little bit of space. I come up over the next submandibular gland, and I push straight down under the mylohyoid. And then I just did this. I find this not inconvenient to do. You want to walk around the other side and do the other finger, it's fine.
On this side, you're starting here, and this side, you said I went down here. So where
That's
am
not what I said. I started here, and then I just turned my finger around.
Okay, so you're not working in this space up here.
You're not, no.
Yeah.
No,
Are
we're
you able to
going to,
touch?
we're going to do
here to
something in
here?
this space. We're going to do something in this space.
Is it all
Medial
soft
pterygoid.
tissue that you're able to
Yep.
able to connect right in there?
But we are going to do something bony up here as part of this weekend, and we've yet to do pterygoids, which is going to be really wonderful. So,
Are you pushing it against the bone, or are you pushing
no,
under
no,
the
no,
bone?
under the bone.
So you're doing kind of dragging.
It's
it
all
down.
fascial,
Like that.
all
Okay.
fascial. But this fascia is not disconnected from whatever other cranial tensions that they have. You know, the whole fascial conversation that we either did have or didn't have. Fascia has a tensile strength, a functional tensile strength of about 45,000 foot-pounds per square inch. 45,000. I can't even lift 45,000 pounds. I think I'm headed off to weigh 45,000 pounds, but I can't lift 45,000 pounds. So what I was taught in school is that fascia had a shearing strength of 2,000 foot-pounds, because it's what everybody said forever, and I actually researched it, and I found it. It's much stronger than we ever conceived of. So you release this, everything else that's floating in and around there. We can talk about the hyoid bone and what goes in and around it. Physically attaches down to the sternum, down to the back of your shoulder blade, through the omohyoid muscle, through back to the stylohyoid, back to your skull. It's a pretty broad range that fascia is contiguous with.
Steve, where did you have your other hand?
It was like here, because it's not doing anything. I mean, what I was shown was to put the finger here, bring this finger to that finger. And I very quickly just realized this is of no value. The only value of this is teaching it to a medical student who can't figure out how to get from A to B. Okay, but as a body worker, you're going down, and the eyes are going to start to flutter. Okay, and I go, well, that's about as far as I'm getting down. After you do this enough times, you'll be comfortable. You'll be like, yep, I feel something's tearing here. There's no way it feels good. But you want to take them just to, when I see the hand, I can feel the innervation coming down the hand to raise. That's when I want to not go beyond that. Your response when you do this, as you already felt, everybody's had this done to them, it's quite regional. It's not a mouth technique, it's a head, neck, maybe more than that technique. So there's emotional components, there's a pain component, and there's all these muscles, my grandfather used to say, all the muscles in that region are going to be affected. How are they going to be affected? You're going to put a massive amount of afferent information right back to the cranial nerves and back to the spine. Here's a little just physical diagram showing you suprahyoid, above the hyoid. We release these muscles, we release these fascia and muscles. These are all the direct muscular connections that you have. I distinctly remember getting a lecture in class about our teacher and all of the omohyoid cases that he solved. The omohyoid is this little string of a muscle that loops around the hyoid and goes to your scapula. And when he told us that,
Told you what?
all the shoulder problems that were because of the omohyoid.
How come that little muscle?
I can't believe that. I just, when you're in medical school, you are, what is it? You're a captive audience for some people that are just, whatever they are or they're lacking in life, they're damn well going to try and impress you. So if there's a bunch of omohyoid cases out there, I just haven't seen them. Although my teacher told me the world's full of them. Okay, and if you studied anatomy like they made us do, it's this little skinny, stringy muscle here. Really? That's what's causing it? Nothing else pulling on the shoulder? Is it possible? Yes. Is it probable? Not too likely to be the only culprit. But just for to be extreme about it, we do have physical connections all around the head and neck. So the reactions are large. And I'm doing this for a regional complaint, or as a component of an ocular complaint, vestibular complaint, neck pain, jaw pain. Mary told me that you have a problem with your jaw and the disc, right? If your disc is damaged, clicking, popping, nothing that I'm going to do is likely to change that. Sometimes I've had the pops and clicks change, but I never even, that's not what I'm going for, because I don't know that it's ever it's staying that way. So when someone tells me my jaw is clicking, my next question is, do you have pain? Is something bothering you? Because I don't know if that clicking is going to go away from what I do. What I understand from being lectured to by dentists is if you're having a pop or a click, according to them, you are already in one of 5 stages of Piper classifications, each with 3 substages, which means that it's in some point of degeneration and will never go backwards, according to them. I don't know if that's true or not, but I know they know a lot. Okay. So we're going to cause a lot of pain here. You have your ansa cervicalis here. You're going to get a lot of reflex back into the head. Sometimes we can look at it like a...
Very sorry.
That's okay. Like you have a wrinkled bed sheet here, and sometimes causing pain or causing a lot of reactions, just like fluffing the sheet up in the air and hoping that the body finds a balance. And I think that happens a lot. It finds its own homeostasis. Okay, so this is what we just did. Again, I can't really show it. I don't know another way to show it. So we were between the tongue and the teeth. It's inferior laterally. That's the real big deal, inferior laterally. But I'm telling you, I go a little bit posterior. I want to get my starting point posterior. And I wish I knew a better word than ream. That really sounds like it shouldn't be a medical word. Because I know we got reamed out in medical school constantly. But that's what we're doing. The fingers just go like this. So go towards the mental symphysis, we were taught to use the outside finger as a guide. I was taught to do this side, put the glove in the other hand, well, actually get a new glove, and then do the other side. But I do it exactly the way you saw me do. I do this, turn my wrist around, and it's no problem at all. Can't use this finger, it's just not long enough. Am I doing this on babies? No. They don't have the accumulated stress. Even the very, very, very sick kids. I'm doing cranial stuff and other fascial things in a different way, but not this. Does that mean it can't be done? No, I'm just not. I think you could have a higher chance of damaging one of their glands with your finger. But the adults know they're probably going to stop us before then. I can only guess that case you're telling me about is that person must have been squealing in pain, and the other person must have said, we just need to do this and just bite the bullet and then damage them. But when someone's squealing in pain for me, I'm done. Check, please. I'm going to stop. Okay, so that's suprahyoid. So I'm going to go 1, 2, 3, 4, done. And you should look at that a couple weeks from now. If you're looking at it twice a week, you can do it twice in a week because the first time you just had to play with them. They really wouldn't let you do it and there was too much pain, so you did sort of something. I want to complete that I did something, that I didn't let them walk away from the session and the treatment didn't happen because they were afraid or it was too painful. Just pretend, because the next time you can pretend more and probably get something done. It's important. Now we're going to do the tongue. Yeah. Ooh. If you like the last one, you're going to love this one. Little finding. The two sides are never going to be the same as far as what I palpate. One side always feels tighter to me than the other. And another just observation I made. If the right side was tighter on the suprahyoid muscles, I find most of the time that the tongue is tighter on the opposite side. Not always, but most of the time.
Say that again?
If I was reaming and I said it's much tighter on the right suprahyoid fascia muscles, if that's tighter here, then the next technique we're going to do, I usually find, but not always, but usually find that the tongue is tighter on the opposite side. And that goes along perfectly with Steve Sand theory number 507. Most of those theories are movie theories, so they don't actually involve osteopathy. But 507 is That is, you could count the frenulum maybe as a diaphragm in thinking. Because I see that a lot in the body, that if the hip's tight on one side, they got something else compensating on the other side, and on the other side, on the other side. I mean, stresses travel through your body, through fascial planes. And we all are adapting to our mental, physical traumas. And it's not problematic to be tighter on the right than tighter on the left, unless you're complaining. So that's what I find. Does it mean something? No. Who am I doing it to? Somebody symptomatic. I'm not doing this as part of a general wellness treatment. I don't do too much of that. I did with the Amish because they have this in their head. It's been pumped into them from other people that they need a treatment to be well. I have informed people, hey, I don't think we need to do anything. But there are some people who want it done. Do I think you're going to be better if you get body treatment a lot? Yeah, I do. But I'm just kind of conscious. I'm conscious of what it costs for them to come in and lay the money down. And it's much cheaper to get a massage, and that's going to feel good. If you're really feeling well, I don't know why you want me to do something. And I want to make sure that we're all clear, because a lot of people are telling people if you don't come in, you're not going to be as well as you could be. Blah 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 blah. That's just a money grab. Okay, so we're going to do something for the tongue. Genioglossus. Genioglossus. We were taught to do our rapid mental exam for. You brought in Grandpa, and he's been slurring his words, and half his face is dragging. So we do a very rapid exam for the cranial nerves. And there is something unique about the tongue and its innervation. You know what it is? About the hypoglossal nucleus? What do you know about a stroke? They can't move their left arm. Where's the problem? Right side of the brain, right? For the tongue, it's ipsilateral. It's on the same side of the cord, so it's kind of unique. So if you're not sure, we know what happened to Grandma. You ask her ask her to stick her tongue out. She's had a stroke on the right side because the tongue will deviate to the side that has had the stroke, because the nucleus, which is where the cell bodies are for that cranial nerve, is on the same side of the body. It doesn't cross over. So now I'm going to do the same thing. I'm going to be medial and inferior, and I'm always going slightly posterior. I want to get as far as I can. And I'm using pressure against the side of the tongue. I'm not reaming. My osteopathic reaming technique, not doing that. It's more a placement and a push. For today, any questions? The answer is 7. The answer may be 7 to whatever your question is. Daniel, do you have any questions? All right. Tomorrow, I want an answer as to what new media is. You can't tell me you're studying new media and you got nothing for me. Yeah, I want to hear what the new media is.
I'll come prepared.
Come prepared. Okay? Before you go, I asked you to remind me, and I forgot. Language. Mitch brought up a good point. He said, maybe you shouldn't tell them that it's going to be painful, you should tell them it's uncomfortable. And I'm telling you, I'm using the P word, pain. With my patients, I say this might be uncomfortable. I never say this is going to hurt. I say this might be uncomfortable. But then I told patients who know me, I've done this for a while, we have some kind of foul jokes going back and forth between some of my more blue-collar patients. I'll say, John, this is going to be a little uncomfortable, and he'll give me a string of expletives with what uncomfortable means, because I've already done sigmoid colon and I've done all this stuff to him. So I don't use the word pain with him. I just say this might be uncomfortable. So good point. So we will resume our shenanigans at 9 o'clock, and hopefully the people that are actually supposed to unlock the door will actually share that same dream for us to be here also at 9 o'clock. So thank you, good news, and good night.